Committee Room 29, sound. 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 Committee Room 29, Sound.
Today we have two oral briefings. The committee will be briefed by the Department on the Inquiries Implementation Programme and the Being Open framework as well, and then we will consider a written brief on Respite Services. We also will be considering papers in regards to our launch of the inquiry on access to palliative care services. So I declare the meeting open to the public. And just to remind members that the committee meeting will be recorded and broadcast through Parliament buildings as normal. And if members and anyone in the public gallery can keep their phones on mute as well, and no photographs or recording of any of the meetings permitted. I've had no apologies. And as said, Linda and Diane are both joining the meeting online. Is anyone aware of any other apologies? Just Alan we're waiting on now, is it? Okay.
How you doing?
Okay, members, so item number 2 under Chairperson's business. There's a couple of things I wanted to raise. The first one's just to welcome the Minister's statement this week on the children with disabilities, short breaks and respite. I think that's a very welcome step forward. It is progress. Some of us, I know, certainly our party, we've met with the families of the It's Not Okay and the Forgotten Voices campaign this week, and we'd also met with organisations, so I know it's been welcome for them. I suppose we need to see how this will, what it look like on the ground, but certainly a step in the right direction. So I've Linda and then Orlea. Linda. Can you hear us, Linda? I'll come back to you, Orlea.
Yeah, it was just on the back of that, and I'm conscious. I know that the families that were involved in the Spotlight programme, I think they met with all the political parties. I know that certainly they've mentioned that they met with quite a few, so I think it was a good announcement for them. But I know that there was issues that they wanted us to follow up on, and again they've probably reached out to all of the parties on this. But I think there was some of the specific points of follow-up that we could maybe write to the Minister on, Chair, if the rest of the committee members are content. And it was just some queries in terms of you know, how the money would be distributed in terms of residential and respite places, how the Minister was going to sort of stay in touch with the Trust in terms of how they're going to deliver that, how they were going to involve people with lived experience and organisations who's involved in this work, and then just importantly what was being done to help the individual families that were involved in the programme. So again, I'm sure that the group and the families have reached out to everyone on that. So it's just if we can get a letter sent off to the Minister on those specific requests.
Yeah, if others are in agreement, I'm happy to do that. I think any clarity we can get around that. Linda's struggling to get off mute. I don't know if we can try and unmute her from this end.
Yeah.
Oh, there she's now.
Sorry, Chair. Yeah, it was actually from that end that it wasn't allowing me. So apologies for that. Apologies that I can't put my camera on, but I just wanted to come in on the back of the point that yourself and Orlea made there in relation to the announcement. I think we need to very much hold the department to account around this money, because we cannot allow the continued inequity between trusts in regards to respite and short break. Now, it isn't good right across the board. There isn't any trust that's doing well on this, but there is certainly inequity where some trusts are doing worse than others. And I also think we need to look at how we actually are going to deal with the workforce issues. So that's a departmental responsibility. And I think that we need to very much hold the department to account around this money. The worst thing that could happen, for me, the worst thing that could happen is that this investment happens, that families' hopes are raised in terms of what they can expect to get, and then only to be completely dashed when nothing is actually delivered. So I think we as a committee need to be very, and I know, to be fair, it's something that the committee and the chair has been very strong on around this issue. I think we as a committee need to hold the department to account around this and to ask them, really based on what Orlea said there, is around what work the department's going to do with the trust to look at how this money's being spent, how it's being invested, and then on the other end of that, what is the actual benefit to the families? Because knowing how it's spent is one thing, but are people who actually need it receiving the help they need? And what is the engagement and co-design, I would actually go as far to say, with families and with service users? Everything that they should be at the heart of every single thing that's done in this particular area of work.
Yeah, no problem. Thank you, Linda. Alan Robinson.
Thank you, Chair.
Look, Chair, just in the same as what other speakers have said, that we need to see, you know, we've seen before the devil's in the detail and the stuff. We've seen GP indemnity, where they had 5 million, and there was a lot of fanfare about that, and it ended up, it was repurposed money from a wider package. And GPs are saying that it amounted to diddly squat. So on this one here, I think we need to be across it and ensure that the money is going to where it needs to go. Now, I see it refers to up to 13 million. Do we know where the baseline is to that? Up to, is it 10 million? Is it 9? Or can we get some clarification that it is actually 13 million and it doesn't stop short of that, because they need every penny?
Oh, absolutely. Thank you, Alan. Nuala?
And thanks. I echo everything that everyone else has said. I think I just want to also make sure it's, you know, to put it on record, thanks to the 4 mums who actually participated in the programme, and for Tara Mills for actually pushing it too, and for their kids as well for allowing them into her home. But I think that we need to be honest in that it did take a spotlight programme. We have been raising this from our very first committee meeting. We raised the issue of respite, but it took a spotlight programme for the department to actually move and do something. We knew that there was multiple JRs, there was multiple legal issues, and nothing had been done before that. And I think that's shameful that it takes the media to actually get involved in something to force the hand. At an ICON conference last week, there was a fringe session on children's social services and the review were next. And there was a mention at that conference session with regards to the RQIA rules around the short breaks and the long-term placements, and that there was a possibility of RQIA changing their rules to that. Now that was mentioned at that fringe session but was not included in this statement, so I don't know if the Minister ever went through with it, but there were many people in the room, so if we could include that in the correspondence with regards to the RQIA's actual guidance around it, and if that is going to be changed, because that may release, it might only be 1 or 2 beds, but it's still a number.
Oh, thank you, Danny.
Thank you, Chair. Yeah, it's the same as other members. It's obviously a very serious issue, but good to see. But we need to see more of the detail. Could I suggest that we revisit this early next year at some point and make a point of revisiting to see what has actually changed, what has been implemented, and to hear from the people on the ground, particularly the families involved. And could we also include older people as well? Obviously adults, respite services are still in quite a poor situation, and if we could get some answers on that. Certainly I've received a lot of correspondence about adult respite services. These children are going to become adults, you know, at some point. So
I think, and particularly around adults with learning disabilities as well. So I think that's that is a key element. What I would suggest then is maybe that we request a briefing from officials to the committee on the actual plans, if members are agreeing to that. Agree.
Just some time though.
But yeah, no. Once they're in that position to do so in the coming months, I would imagine. So if we're happy to do that, I think that would also be useful, and then we can track the progress of that and how that's actually being felt on the ground. But if we can get answers to those more immediate questions, I think that would be very useful as well. Okay, thank you, members. The only other 2 things I wanted to mention under Chairperson business, because there have been quite a number of announcements this week, was today we saw the announcement of the Live Better initiative around tackling health inequalities, and I know the Minister's then announced his 2 areas that he will be targeting in the first round of this, and then I suppose the Professor Mary Renfrew report into maternity services, which I think has also been very useful. It's good to get that at this stage, and we could hopefully get Professor Renfrew into committee as well. I think would be good. So we'll make a request for that as well, if that's okay. Okay, thank you, members. The draft minutes then at page 6 of your meeting pack. That was our meeting on the 17th of October last week in the Le Mans at the NICON conference. Are members content with the minutes as drafted? I have no matters arising if anyone has anything to raise in that. Okay, then members, we might move on to our first oral briefing from the Department of Health on the Inquiries Implementation Programme. If I can refer you to the papers at tab 5 of your pack, which includes the Departmental Briefing paper on the Inquiries Implementation Programme Management Board at page 15. We have the RQIA review reports of the Southern Trust Urology Services Phase 1 and Phase 2 at pages 31 and 82 respectively. We also have the Southern Trust Urology Look Back Review Outcomes and Activity Report for Cohort 2 at page 138. And we have excerpts from the INI and IHRD inquiry reports listing each report's recommendations at page 165 and 174 respectively. So there's quite a lot of documentation there. However, as members will know, these are issues that we have been considering for some time, and ties in with a lot of the stuff we're focused on our priorities. So I'd like to welcome today, we have Michael O'Neill, Interim Director of Quality Safety Improvement Directorate at the Department, Robbie Davis, the Director of General Healthcare Policy Directorate, Anne-Marie Boville, Healthcare Inquiries Oversight Directorate, and Patricia Donnelly, the IIPMB Independent Member and Chair of the Assurance Subgroup at the Department. So you're all very welcome. We really appreciate you coming today. We have about an hour in total for the session, and it will be covered by Hansard. So if we can ask you to make your opening remarks, and then I'll open up for questions. So thank you.
Thank you. So good afternoon. I would like to firstly thank you for giving me the opportunity to speak with you today. I am Robbie Davis, Director of the newly formed Healthcare Inquiries Oversight Directorate, and I'm joined by my colleague Anne-Marie Boville and other colleagues you've introduced. Also joining us today is Dr. Patricia Donnelly, Member of the Inquiries Implementation Programme Management Board and Chair of the Independent Assurance Subgroup of the Board. Anne-Marie, Patricia and I will try our best to answer any questions you may have relating to the I&I Implementation Programme. Michael O'Neill, Interim Director of Quality, Safety and Improvement Directorate, also here today and will provide opening remarks and cover any questions you may have in relation to the inquiry into hyponatremia-related deaths implementation programme. May I firstly take the opportunity to acknowledge the significant healthcare failings that have been identified from the independent neurology inquiry and how these matters have affected the patients and families involved. I can assure you that the Department continues to listen to patients, families, support groups, charity groups and political representatives, and we are committed to the overarching principle of enhancing patient safety, which the I&I report sets out. A written briefing paper was provided in advance of today's meeting, which provided an overview of the Department's Independent or Inquiries Programme Management Board and updates on IHRD and I&I implementation programmes. An update on the Urology Services Inquiry has also been provided. I hope that members have had the opportunity to consider the written update and found that helpful. And in order to avoid the risk of repeating the content of that briefing, if you are in agreement, Chair, I would like to take the opportunity to highlight a few key points. Thank you. So, firstly, in April 2023, the decision was made to amalgamate the inquiry into hyponatremia-related deaths and the Independent Neurology Inquiry Programme Boards into a single DOH Programme Management Board. This approach was taken due to the commonality of issues across both inquiries and to support a consistent approach to the alignment, engagement and assurance requirements relating to the implementation of inquiry recommendations. The common themes which appear within the IHRD and I&I public inquiry reports include assurance and accountability, which are divided into 3 work streams, those being workforce, quality and safety and governance, and information and data management, which are divided into 2 work streams, information systems and information sharing. The IIPMB is chaired by the Permanent Secretary, and membership comprises key policy and professional leads from across the Department and external experts. You will have a list of the full membership in the briefing that was previously provided. Members will note that 6 IIPMB meetings have been held to date. Stakeholder engagement and assurance are key elements to support the implementation of public inquiry report recommendations. The IIPMB structure includes robust, independent assurance and bespoke engagement arrangements to support the implementation of public inquiry recommendations. Arrangements are currently being made to expand the IIPMB remit further to include the implementation of recommendations from the recent Infected Blood Inquiry report published in May of this year, and the Cumberledge Hughes reports relating to pelvic mesh and the prescribing of the medicine sodium valproate. There is also the potential in due course to consider the implementation of other relevant public inquiry reports when published, such as the USI and Muckamore Abbey Hospital Inquiry under the scope of this Programme Management Board. Moving on to a few key points regarding the I&I implementation programme. The I&I report was published in June of 2022 and included 76 recommendations for the Department, healthcare organisations, the independent healthcare sector and the GMC to ensure patient safety and reduce the risk of similar events happening again. Ensuring that the recommendations are taken forward, implemented and critically deliver the improvements intended is a priority for the Department. The Department published an overarching I&I implementation plan on the 27th of July 2023. The I&I action plan, which outlines the specific actions required against each recommendation, was published on the 7th of March of this year. The Department considered the feedback received following the sharing of the draft implementation plan with stakeholders prior to publication and established 2 key independent groups to support the implementation programme. Those are, firstly, the IIPMB Assurance Subgroup and secondly, the Independent Neurology Liaison Group. Independent assessment of each recommendation is provided through the IIPMB Assurance Subgroup, which makes recommendations to the IIPMB in respect of actions required for each INI recommendation and whether each INI recommendation has been fully implemented. Progress at each stage is reported to the Programme Board in order to provide oversight and approval. The Independent Neurology Liaison Group aligns with the work of the Assurance Subgroup to further enhance feedback and recommendations from the service user, carer and families on the assurance process and implementation programme. The Liaison Group currently consists of 14 members, comprising of patients and family members of patients. Membership of the group remains open to service users, carers and families who would like to be involved. The current position regarding the INI implementation programme is that 22 recommendations out of the 76 have been verified as implemented following review by the Independent Neurology Liaison Group, scrutiny by the Programme Board Assurance Subgroup and approval by the Programme Board. 44 recommendations are progressing through the INI engagement and assurance arrangements by theme and in tranches, and 10 of the 44 recommendations have agreed frameworks and action plans in place. A further 19 recommendations will be presented at the next Programme Board meeting in November, seeking approval of the assurance frameworks and action plans along with evidence of partial implementation and full approval of implementation as appropriate. One recommendation will be deferred as primary legislation is required. It is important to highlight that the pace of progressing the INI recommendations through the Independent Neurology Liaison Group and the Assurance Subgroup may vary depending on the complexity of the recommendations. The positive and constructive engagement provided through these engagement and assurance arrangements is very much welcomed. Delivering the changes identified by the INI requires a series of coordinated actions, and the Department continues to engage across a range of organisations. These include the GMC, healthcare organisations, the Trust and independent sector. Many of the actions to be taken to implement the INI report are aligned or interdependent with other DOH work programmes and work being undertaken in parallel by other relevant organisations. It is clear from engagement with key delivery partners that further improvements to governance systems and processes have been made, and there is an acceptance that more work is required to ensure full implementation of the INI report. Notwithstanding the progress already made to implement recommendations, the IIPMB will only confirm recommendations as implemented once they have passed through the assurance and engagement processes. Finally, before I pass over to my colleague Michael, I would like to briefly touch on the ongoing Urology Services inquiry. The written paper provided on the 18th of October included an updated position on the USI, which was established under the Inquiries Act 2005 and is chaired by Christine Smith KC. The USI setting up date was the 6th of September 2021. Members will be aware that the inquiry is wholly independent and not accountable to the Department of Health. As the inquiry remains ongoing and is independent from the Department of Health, it is not possible for the Department to provide timescales for the completion of the inquiry, and we can provide the assurance that the Department will, of course, consider the USI report, including its findings and recommendations, when published in due course. Thank you for the opportunity again to present, and I'd now like to pass over to my colleague Michael.
Thanks, Robbie. Thanks, Chair and members, for the opportunity to provide an update on the implementation of recommendations from the inquiry into hyponatremia-related deaths. Today I'll provide a short briefing on the background to the ongoing work and progress to date across the range of work streams. In January 2018, Sir John O'Hara published his inquiry report, which examined the deaths of 5 children in hospitals in Northern Ireland. The report made 96 recommendations, which were wide-ranging. A number of these recommendations include multiple parts, and as a consequence there were 120 separate actions to be addressed arising from the inquiry. Whilst today we'll discuss the progress against recommendations and actions, it's important at these moments to reflect on why we are undertaking this important work. And it's because of the failings that led to the tragic deaths of those young children who, along with their families, were so badly let down. Following the publication of the report, the Department established a hyponatremia implementation programme to address the 120 actions. This work was paused in March 2020 to address issues arising from the pandemic, with the programme restarting in April 2021. A scoping exercise was completed on each of the 96 recommendations, with those recommendations closer to completion identified and any outstanding actions progressed. 69 of the 120 were fully implemented in what was known as Phase 1. The remaining 51 actions are being dealt with within Phase 2 of the implementation programme. Of the remaining actions, 15 relate to duty of candour being open workstream, 21 relate to serious adverse incidents, 4 relate to RQA functions around the duty of candour and serious adverse incidents workstream, 1 relates to the establishment of an independent medical examiner, 7 relate to workforce actions, and 3 relate to issues around clinical negligence and litigation. The implementation of the 4 recommendations related to RQIA are all dependent on the implementation of a statutory duty of candour in Northern Ireland and the new SAI process. The implementation of these actions will therefore follow those work streams. Regarding serious adverse incidents work stream, members may recall the written and verbal briefing provided by my colleagues at the end of June on the work being undertaken on the development of a new framework for learning and improvement from patient safety incidents. By way of an update, that programme of work to redesign the existing serious adverse incidents procedure is ongoing and on track for the department to launch a 3-month public consultation towards the end of this year. The committee indicated at that briefing that it wants to continue to be updated on progress in relation to the new framework and has requested an update on the consultation plans. A further written update will be provided in the coming weeks in advance of that consultation period beginning. The committee is also scheduled for officials to provide a further oral briefing in March following the consultation to include the outcome, progress and plan next steps as we move towards implementation. Turning to the introduction of an independent medical examiner service, this has been a recommendation of a number of public inquiries and reports. The purpose of the recommendation is for the department to institute the office to scrutinise these hospital deaths not referred to the coroner. Whilst the IHRD recommendation made specific reference to hospital deaths, it's the intention that any IME service in Northern Ireland will also review deaths in the community. This has been the approach in the rest of the UK. An IME is concerned with 3 primary functions. Firstly, ensuring that deaths are appropriately and completely reported to the coroner when required. Secondly, reviewing the quality and accuracy of medical certificates of cause of death. And thirdly, identifying any safety or governance issues relating to deaths at an early stage. Work to conduct prototypes for statutory IME service for Northern Ireland has been ongoing since 2020. Initial work to consider the feasibility of using electronic care records to determine the accurate cause of death was undertaken in late 2020 and the first prototype began. February 2022, all hospital deaths certified between 8 and 4, Monday to Friday, were subject to review by a team of 10 IMEs working on a rota basis. To date, 3 prototypes have been completed to determine how the service might operate in Northern Ireland and what the implications might be. Prototype 3 was paused in October 2023 to allow a full evaluation of the service to take place and for plans for future prototypes to be developed to include a review of deaths by GPs in the community. The next stage of the process is to conduct a further prototype to identify the implications for reviewing deaths certified in hospitals out of hours and at weekends. These will commence in the next few months together with more detailed plans for reviews of deaths in the community. Once the full implications of these reviews has been undertaken, proposals for a statutory system can be developed in partnership with DOF, who are responsible for death registrations, DOJ, who are responsible for the coroner service, and DFC, responsible for burial and cremation policy. This is a cross-departmental issue and will require new primary legislation and full public consultation. A detailed briefing on the Being Open framework and duty of candour has also been provided separately to the Health Committee for consideration. Following this session, colleagues and I will provide a more detailed briefing across this work stream during which we can pick up any duty of candour issues members may have. I started in this post as interim director at the end of September, and already I've seen how much work has been undertaken by a few small but dedicated teams in recent times, many of whom have also been impacted by the significant demands to support the COVID inquiry. Across these IHRD work streams, there's still much to do, however. Over the next 3 or 4 months, we will see significant milestones reached in all 3 of the SAI, IME and Being Open duty of candour work streams. Whilst this work is challenging and complex, there is a momentum across the system that is welcomed and which the Department is keen to translate into practical improvements to the provision of healthcare in Northern Ireland. So thank you and happy to take any questions members may have.
Thank you for that introduction, both from yourself, Robbie, and Michael. If I can just start with a couple of questions, and if you can't answer them, just say it, because obviously we have a lot of information here and we know we have another briefing, so some may overlap. I suppose the first thing I wanted to say is just in terms of the hyponatremia, today is the 28th anniversary of Claire Roberts' death, and I think it's important to acknowledge that, and that also gives us a sense of the time that families are waiting to try and bring a conclusion to lots of these issues. And I appreciate there's been a lot of work done and a lot of work ongoing, but I think that has to be at the forefront of all of our minds, that these are real lives, people's lives that are impacted, and just to mention that. So I do welcome, I mean, there are common themes across all of these inquiries, and we have talked about this as a committee in terms of recommendations and what is being, you know, what has been seen as could help to avoid these situations in the future. I think for all of us, that's what we would like to see, that we're not seeing. I mean, I think even in the time this committee's been in place, we are aware of numerous inquiries, and the vast majority of them are all saying the same things. Yes, there'll be nuances between them given the specifics, but for me there are a lot of very common themes, and I think that's what we need to tackle. And I suppose on the back of that, would it be possible for the board to commit then to providing even a table of given the detail across each of the individual recommendations, in terms of when they're implemented, what the progress is on them, even reasons for if they're not accepted? I think that would be very useful for us as committee members, but also for the public, to be able to keep a track on what's happening and where things are at. So if that is something that we'll be able to consider, I think that would be very useful.
Yes, I'm certain that we will be able to provide something along those lines.
That would be great. No, thank you. So I just leading on from that, Michael, you had mentioned around the SAI redesign, and we do have meetings coming up with some of the people involved with that from the families and who have been impacted. I would like to understand a wee bit more about that co-production and what that's looking like. I mean, is it? Do you feel that it's meaningful? Is it working really well? And going forward, because I think that the panel was only set up December last year. Is that right? Or
yeah, the initial SAA work stream, obviously that started in 2020, there was a lot of co-production involved in that. So whenever this work was restarted, we have an engagement panel now through the PCC that we have. We also have 3 family members, 2 of who have an experience of the SAA process as it is now, and one with an interest in patient safety on our project structure. So there's two different approaches we're taking there. There's no doubt that we've met in person with the PCC engagement panel twice now. We've taken written evidence from them as well, and there's significant issues that they have with some of the proposals. And I suppose that group in particular have had a very, very, very traumatic experience of the current of an incident in general, but of their experience in terms of the SA process. So we're listening very carefully to what they're saying and what our other engagement members are having, and then we'll move to public consultation, because we're keen to hear other people who have had other experiences of SAA processes, so that all views can be taken account of.
Okay, and the committee are meeting with the engagement panel and the PCC in the coming weeks as well, so we'll probably have maybe more questions coming out of that. But I suppose for us, we want to make sure that kind of co-design, co-production is really, really strong, because that's the only way I think we are going to achieve proper learning and change things for the better. I mean, it may be too early to say, but as I've alluded to, it's the time that a lot of these things take. It's just soul destroying for families who are impacted, and I'm dealing with a case, and I know we won't mind me mentioning them. Charlie, as a wee boy, it's 11 years it's going on, and from he was born, and they're no further on. Is that something that is being considered as part of this redesign of how long it can take for cases? And in Charlie's case, there was a number of different failings, and that has been outlined already, so I'm not saying anything that isn't already known, but I think certainly for that family, what they would like to see for families come behind them who maybe are in a similar situation, that they shouldn't have to wait this length of time. That's one of the key things, that families are waiting too long for the reviews to take place. Many SAIs should be undertaken very, very quickly, and the feeling in the sector at the minute is that the system doesn't provide for that to be able to happen. So what we're hoping to establish is a more proportionate system for those SAs that can be delivered quickly, which will free up resource for more complex cases that will take more time and involve more investigatory work. But timeliness is absolutely top of the
the agenda in terms of what we need to deliver on.
Yeah, no, absolutely. And I suppose then on the back of that is that in terms of implementation coming out of that, that also needs to happen quickly, and anything that's being offered to families so that they can get their lives back on track as well. So I suppose that's a key part of it as well.
A key part of that is a compassionate approach to families during that process as well.
Yeah, okay. The other thing I was going to ask around that is around collaboration, and that collaboration across the different departments. So, I mean, the Caudry case is a prime example, and I know some of their family are involved with the engagement panel. For me, coming out of that case is the need for proper collaboration between health, PSNI, justice, all of those departments. Is that something that we are looking at as part of this redesign as well, that we need to improve on those areas?
I know there has been engagement with those organisations in the last 12, 18 months. I haven't been involved in myself yet, but they have been engaged with, and as part of the public consultation we would expect to engage again with folk around those issues.
Yeah, because I think, in many of these cases there are a number of different agencies and departments involved, and things fall through the cracks, and that's how we end up in the really horrendous situations that we are dealing with through the SAIs and through the inquiries. So I think those are really, really important, particularly when you're dealing with things like mental health patients and that, like that, in that example I gave. My last question then is, and I appreciate if you maybe can't answer this, but duty of candour is something that's really important to this committee, and we are hoping to take forward some work in relation to that, and that is the common theme across all of these inquiries around individual and statutory duty of candour. Are the board able to give any views in relation to how they think that should be pursued? Is that something that you can comment on?
Like the next session, if you don't mind,
okay,
we'll have a briefing around that, and Peter and Ian behind me, we can brief on those specific issues, and we'll try and be as transparent as possible in those issues, if that's okay. Okay,
that's no problem, thank you. Robbie, just my very last one then, very last one, sorry members, but it just came into my head because I had it in mind. The urology review, you had mentioned there, obviously it's an independent review and there's things you can't comment on, timelines and things like that. Does that mean then that you don't really know then when you will receive the action plan from the trust in relation to that, or do you have to wait till you see what the review brings back?
Well, the Urology Services inquiry has finished its hearings. It's now in its final stages. How long that takes is really a matter for the inquiry. I know that they will be keen to publish their report at the earliest possible juncture. When we in the department receive the report, we will be assessing it and analysing it as you would expect, and working with our partners in the trusts and the GMCs and other relevant organisations and stakeholders to develop any necessary action plan to progress the recommendations from that. But as you say, Chair, it's difficult at this point in time to know what will be the outcomes and the recommendations from that inquiry, although as has already been noted, there are certain common themes that we have seen across prior inquiries.
Okay, no problem. Thank you, Robbie. Danny?
Thank you, Chair. Thank you for coming today. There are quite a lot of common themes, as the Chair has alluded to, throughout these inquiries. And failure of clinical governance is one that you do see quite again and again cropping up. This impacts the public's confidence in the health service, and I'm just wondering how you're going to be able to restore public's confidence in the health service. How does that apply to the work of the board, in particular accountability and transparency?
I'll say a few remarks on this and then pass over to my colleague Patricia, but ultimately I think it's important to acknowledge that the circumstances that have led to the public inquiries have certainly dented public confidence in the healthcare system. We acknowledge that, we recognise that. The inquiry reports are extremely helpful to us as a department to pinpoint the precise areas in which we need to drive improvements across the wider system, and I believe through delivery of those recommendations that we can help rebuild public confidence in healthcare systems. But I'll pass over to Patricia.
Thank you very much. Well, I think you've touched on one of the most important issues here, that in all these inquiries they have raised issues around governance and who knew and what was done about what they did know and what the control systems were in place. So when the hyponatremia inquiry reported, one of the first things that happened, I think I was involved again in providing assurance at that stage as well, was to look at how could we introduce a system whereby you not only put in place the things that were there to improve, but how would you know that they would improve? You know, there's a moment in time when everyone's face is turned towards the outcomes of an inquiry and making sure the right things happen, and indeed some things have to happen immediately for the safety of patients and clients. But some of the governance works takes a little bit longer. So there's a number of recommendations within the hyponatremia report, and there are a number of recommendations within the independent neurology report which cover this off. So the system we now have in place, I think, is a much more robust one than has ever been the case before. We look at what do you need to put in place so that as an ordinary business as usual, good, robust governance model that the public and patients, that staff, that boards, that you can have confidence in. So first of all, we take the recommendation itself and we then define what that actually means, because recommendations are written, but they may be interpreted in many different ways. So we get an agreement on what that definition is. They then say, well, who should do what and how many individuals? It's often not just for action by one person. What's the scope of this? What are the limitations? How does it link? Because the experience is that an inquiry makes, as you've heard, 76 recommendations in the case of the INI and 96 in the case of IHRD and 120 actions. No single one of those will improve governance, but as a system acting together, it will say so-and-so should, RQI should do this, trust should do that, GMC should do this. So it tells different parts of the system how they need to act together. So we look at who needs to do what. We then say, is there new policy that needs to be introduced? Are there new procedures? Are there existing ones that you need to fix? And having done that, how do you know that it's happened? What is the level 1 evidence? What is happening on a day and daily basis or on a weekly basis at the delivery front? You know, what does the team do? How do they report? What records do they keep? And at level 2, what does the trust do? How do they assess? How do they audit? What is their governance statement? What are their control systems in place? And third level, a very important one, a less frequently available one, is, and for the regulators who go in, whether it's RQAA or GMC or the MHRA or some other regulating external body, what do they say about when they look at the evidence? How is it demonstrated to them that that is in place? So what we've done in the assurance group is we work with the key stakeholders who've been affected by the inquiry. So, for example, in neurology, we have a liaison group that are, I think Robbie has set out the number of individuals. They are also engaged with a wider group who do not want to be directly involved, but who are definitely interested in the outcome. And they sit on our assurance group. So there's a number of independent people, such as myself, who come in and say, we have now looked at each individual recommendation. There's quite an elaborate assurance framework drafted that says all those things. Where's the evidence? Where's the action plan? And we then agree whether it's the right scope. And to be honest, many, many times we change it on the basis of the commentary from the neurology liaison group. And that has been most useful. And what we've done is then gone back to the owners who are accountable for the actions and set out maybe some changes that need to be made. I mean, only yesterday our group met and GMC were in the room with us, the liaison group chairs were in the room with us, and we went through the remaining recommendations that were for action for them. And we've agreed some changes to that framework to increase both the robustness of it, but also the confidence in it that people have. So, and I wouldn't be breaking any confidence to say that the co-chair of that, who is one of those affected by the neurology inquiry directly, has said how much that it is appreciated and the greater confidence they have in this as a process, because it's interactive. It also has validity and credibility for the individuals. It slows it down. I think the chair had said when you do co-production and you do this kind of engagement, it slows it down, but you get a much, much better outcome. And it's only through that you rebuild trust. It's only through that. But you do need that critical scrutiny, and you need people in the room who are prepared to say, this isn't going to work, or this isn't the right thing, or you need to do more. And indeed, I do believe we've had that kind of commentary in a constructive way.
I absolutely agree that co-production is, vitally important, and I'm glad to hear that there is that conversation is part of this, that it is built into that. Obviously, there is a lot of levels to this, and you've mentioned that it does take a long time. Can you point to anything in particular? Can you give us an example of lessons that have been learned that show that patients are safer?
Well, again, if I just go back to the governance issue itself, there are, what are the standing reports that would go? One of recommendation 20 is that there would be the introduction of a safety and quality committee. Now, the liaison group had said that needs to be patient safety. Let's not lose the focus on that. So indeed, that's been accepted by the department that would be the case. And it's to describe a terms of reference that shows what standing reports do they need to know, what's the trend information that they need to look at, how do they know, given that it's chaired by a non-executive, it's calling the executive directors to account for their reports on that. So those are the kinds of improved controls that you can put in place. And if I take another example of one recommendation, which is number 15, and very relevant, I think, to a number of inquiries, which is the practice of lone working. So it's saying there needs to be, and recommendation 42 is what the trust need to do about lone working. And it's saying if you're carrying a risk, and sometimes in a small specialty, there might only be one expert, therefore a person might work alone, that there's risks to patients when that happens, potentially, so that the trusts, again, when we've worked through the framework, what we're saying is trusts need to understand that that risk exists, so they need to be sure that they scanned maybe an individual working within a wider team or a geographically separate place, and they need to put in place mitigation members to actually employ more staff if necessary, build a clinical team around the individual, make sure there's connect them to a wider expert group. It may not be within their own trust, but outside, or indeed maybe outside Northern Ireland for a particular subspecialty, and that they put in all of those support measures that would reduce any risks, but being aware of it and then it being monitored so that it isn't just you do it once and it's over, that you make sure that that is continuous, and that the individuals are supported right through that process. So I think there's some very direct actions that can be taken, but I think making sure that the process is in place, that you are identifying and controlling what those risks are. They may not be absolutely avoidable, but they need to be mitigated.
Okay. Noticed, just as you're on the board as an independent member,
yes,
would you be able to give us your opinion on duty of candour?
I think it. I would prefer not to. Would you mind if I didn't? I have been involved in the duty of candour. I do feel the most important thing is the being open culture, and I think that creates protections for everyone concerned. I am aware of all the challenges that have been around individual duty of candour and the penalties around that, and I think it creates a resistance that doesn't necessarily need to be there from the system. So I do see the bigger prize as being the being open culture and that change, so that in everyday life that people are used to being transparent about what they do.
Thank you.
Okay, no one else has indicated. O'Neill, do you want to go ahead? I have a couple more.
Yeah, I have a few questions, just carrying on from some things that you said, and some questions of my own. I'm going to be flicking back because I have a paper copy. But thank you for coming in today. I just want to go back to recommendation number 2. And sorry, what I should have said though before I begin is also to echo the words of the Chair with regards to the anniversary of the death of Claire Roberts, and to pay particular tribute to the parents of all of the children, Claire, Rachel, Connor, Adam and Lucy, because the hyponatremia inquiry was about them, and unfortunately they lost their lives. But the hyponatremia inquiry was launched, correct me if I'm wrong, 2004. And then with regards to the timelines from between then and now, we've also had neurology inquiry, we've also had Muckamore inquiry, which is still ongoing. We have had the mesh implants, we have had urology, and most recently cervical screening. But between hyponatremia and the cervical screening, which I believe is the most up to date or latest scandal, there has been 120 at least actions and recommendations to be implemented to ensure that it doesn't happen. But unfortunately, the latest scandal was just broke last year regarding cervical screening. So lessons have clearly not been learned. And if we go back to some of the recommendations as early as the hypnotremia and neurology, had they been implemented prior, we could have actually prevented further scandals actually taking place. And I do appreciate all of the work that is ongoing, and it isn't easy. But if I do go back to recommendation 2 of the neurology inquiry, in which it said that the Department of Health should remind healthcare organisations that they ultimately remain responsible for the safety of their patients and accountable for managing their employees, and that, I assume, still stands today and was implemented, actioned, that the management are ultimately accountable for managing their employees. And with regards to, that was in the neurology inquiry. And then in the hyponatremia inquiry in recommendation 33, it also said that compliance with investigation procedures should be the personal responsibility of the trust chief executives. It's kind of similar to the previous recommendations, and where responsibility and accountability lies within trusts. And it's part of the being open, honest, and ensuring that we do have the proper processes. But are you aware of any incidents or serious adverse incidents that actually took place regarding after hyponatremia, so after 2018, before the neurology report that was outlined, that didn't follow the correct procedure?
If I could just start off by saying, firstly, I think patient safety is at the heart of everything that we are doing. All of the inquiry reports that are published have a patient safety focus and are designed to drive forward the agenda to make our healthcare system safer for patients and to minimise and do everything that we can do to drive down the risk of adverse incidents happening within the system. Recommendations across the inquiries have varying levels of complexity. Some are easier to deliver, some, such as those that have cultural dimensions, trying to drive changes in the healthcare culture. Those can be longer to deliver and can be more complex as well. It's our priority to deliver at pace, and I'm reasonably confident that we are delivering at pace. Obviously, there's more to be done. There's a programme of work ahead of us, but all of the efforts that we're taking forward are designed to minimise and mitigate risk of future adverse incidents occurring. Perhaps one of my colleagues might want to add in.
Yeah, I would just like to add to what Robbie has said in terms of recommendation 2. That is one of the recommendations where there is an assurance framework which details the intention and the understanding behind the recommendation, which has also come from engagement with the I&I panel to get a clear understanding of what the intention was behind each of the recommendations. That framework has gone through review through the structures, the engagement structures which we have in place in the Independent Neurology Liaison Group, and feedback and comments have been provided in relation to that. It has then gone through the assurance subgroup, which Patricia chairs, in relation to scrutiny, and it has also been brought through to the programme board, and the programme board have approved the current position on that one. Really is what I'm trying to get to, is that specific recommendation, the framework has been approved at programme board level, so the required actions have been agreed through the engagement assurance process and approved by the programme board, but there's still further work to be done to verify that that is fully compliant with the actions that are required on that.
So then you just said the intentions then, but you didn't actually say what the intentions were. If you went back with regards to the inquiry panel to find out what the intentions of that recommendation were, then is it correct in reading that the intention is around accountability and responsibility within the trusts?
And there is a lot of accountability and governance recommendations which fit within that framework, as Patricia has outlined. Not one recommendation will be taken forward on its own. It will need the collective required actions across all of the recommendations. I'm not sure, Patricia, whether you want to comment in detail about recommendation 2.
Yes, please. We have, and I have personally continued to engage with the authors of the inquiry report to make sure that we and if there's any issues where we're not clear about their intentions in it, so we can clarify that. And that's been very helpful, and I think they've been supportive to us in that. But the issue about patient safety, absolutely, but it's about all the things that you need to put in place. And as part of the process of this, for example, we've been having meetings with trusts. So trusts would have had to say how they fulfill that function. So they've had to audit and report back to us, and they've had to do that periodically. We've also met with them, and in fact continuing to meet with them, and I am meeting with one of the trusts and with the team in the very near future, within the coming weeks, to go through specific recommendations, to look at what they've implemented, for them to demonstrate the evidence 1 level, evidence 2 level, and what external bodies have said about their improvement processes. But these are part of continuous improvement, and one of the things that we've been doing as kind of part of this is identify the need. It was identified during hyponatremia inquiry and the work that was done then, and it will only come to fulfilment now because of the hiatus there was around COVID and that post-COVID period when people were distracted doing other important things, which is to produce an updated governance guidance for trusts that say very clearly what the expectations are. So that strengthens that. That also makes normal accountability arrangements, I think, much clearer to trusts, and I think that it would still be open to other improvements. And one of the other last things that I would say is that following the hyponatremia, the work that was done there, myself and others produced a handbook for directors around guidance on their responsibilities, their legal responsibilities, their governance responsibilities. And in that we included a lot of case examples where there had been failures, and then looked at what they needed to do, how they needed to be curious about situations, how they needed to seek assurance, what they should be looking for in the absence of information that they're given, so that they can see through what would be standing otherwise quite optimistic and positive and reassuring data and information from trusts, that they're looking for assurance, not reassurance. So that a lot of that is ongoing work around improvement.
I asked specifically regarding the serious adverse incidents post the publication of the neurology or the hyponatremia report, the neurology report, and then there's the cervical smear, because then I think the answer is you're not aware. I don't expect you to have the awareness of all individuals. So perhaps you might be able to answer is regarding the serious adverse incident recommendations within the hyponatremia inquiry. How many of those recommendations, and which ones specifically, are included within the review of the SAI process?
There has been some, so in the SAI kind of policy area, there have been some already implemented in terms of appointment of training of executive directors with specific responsibility for learning from SAI related patient deaths. So there's already some that have been implemented very early. Then I think I would need to double check, just because there are a range of the SAI recommendations, but my understanding is that the rest of them are dependent on the SAI work that we're doing at the moment, and there's a significant number of those, and it's a significant chunk of the remaining actions that need to be implemented.
Well, can we actually get feedback as to whether all of the recommendations within a hyponatremia report, which were clearly outlined in terms of these need to be actioned and that they should be, and I recognise departments don't always agree with recommendations, can we get feedback written as to how many of those, if any, and which ones, and not just talking about the ones already implemented, all of them are actually being included as part of this ongoing SAI? Because my worry here is that it is yet another system, it's yet another process that is just kind of kicking the can down the road of actually getting the change. And you can understand the frustration that many families will feel, that they got an inquiry, they got a report, but actually they're still fighting, they're still meeting with political representatives, they still want to actually see the change implemented overall. And I have another question as well regarding accountability. But before I go there, I mean, I'm a bit, the chair asked around the table what recommendations are implemented and what weren't. And like, it's really disappointing that that wasn't already given to us, given with every committee session that we have with officials from the Department of Health. We always ask that every time, no matter what the inquiry is, no matter what the issue is. If there are recommendations, we ask every time which ones have been implemented and which one isn't. So I don't know what kind of, I honestly do not know why, but it's so disappointed that yet again from the Department of Health, we are being stonewalled as to know exactly what recommendations are being implemented, because the public who fought for these inquiries deserve to know what happened with their fight. Did they actually get the change that is needed? And one of the other issues that's raised with us every time that we meet with families is accountability. With regards to the cervical smear scandal that took place, I recognise and respect that stage 1 had to be regarding the safety of every single patient, with regards to whether it was reviewing their slides or any additional treatment that they needed. I absolutely agree that was the right process. And when we recently met with the trust, they said that the next stage was finding out what happened. But that took place, my understanding, is over 10 years. But will you be using the recommendations within these reports to actually find out if people are willing to be open as to what went on, what happened? I'm not saying that there should be finger pointing or anything, but I'm saying it was over 10 years and all these other reports and inquiries were going on, but yet this seemed to be missed by the Public Health Agency, by how many clinicians and what. So how can we use this? How can we use the recommendations within those inquiries into the next cervical smear review? And how will you work with that trust to actually ensure that the proper process is followed?
If I may take your first point, which was in relation to the table, my understanding of what the Chair has asked for is that we provide a list of each recommendation, essentially the state of play for each recommendation, what needs to be done, what's outstanding. What we did provide in our briefing to the committee at paragraph 55 is a summary of the position of all 76 recommendations. That sets out the recommendations that have been approved by the programme board as implemented, recommendations with actions agreed by the programme board where further action is required before implementation is complete, and recommendations which remain subject to consideration through the engagement and assurance structures and approval by the programme board. So hopefully that provides some of what you were hoping to see, and we are of course happy to provide the additional information as requested.
No, I think that what we need is in terms of what, like, the information, because we can read what the recommendations are, but sometimes we have an excuse given that, you know, they take funding, they require work streams to be set up, but what will it take to actually just do it? So, like, with respect, I know this is not an individual fault with any of you sitting at the table, but there are recommendations that have been sitting here since 2018 that they have not been implemented. There is now an SAI review, and my understanding is that I'm hearing is that many of those recommendations around SAIs are not part of the SAI review process. So it just, we get information but we don't get enough. The RQIA, on the other hand, have provided in their pack briefing to MLAs today quite a detailed account of recommendations and what should happen and what shouldn't with and not hyponatremia and urology. And we can't speak to it too much with urology, but there is a bit of a difference here, and the committee, in order to carry out its function, needs to be able to hold the department to account. The final question, I'm not sure who was.
Could I just come in on top of what Robbie has said, and in relation to the member's question in relation to details and the position against recommendations. So I appreciate the written update provided numbers, and maybe a specific number of a recommendation doesn't mean so much, you know, to be able to see the detail behind that. But the department published a detailed action plan in July this year, which outlined the current position, the intended recommendations, and the current status, I suppose, against each recommendation, which hopefully members will find helpful. Obviously, it will be our intention to provide further updates in relation to that as we progress through. And one more additional point, just to caveat that with, although the action plan outlined intended recommendations, you'll appreciate that those recommendations are still going through scrutiny through the assurance subgroup and through the engagement process, and could be subject to further refinement as we go through, to make sure that patients and family voices are heard, as well as independent scrutiny of what the intention is. I think your other question was in relation to...
question, just before that, but I reckon we did have a look at the action plan, and I recognise that there was detail in it, but within that there was also action, so there was recommendations, but out of recommendations there's actions. So if you add all the actions together with the recommendations, you're getting into over 200. So it's not quite as straightforward whenever all the information is provided. And I don't mean this just to be deliberately difficult, but people out there just want to know, has it been done? And I appreciate things are hard, but after 2018 to 24, after 6 years, you should still be able to yes and no, not kind of bureaucratically say why it's stalled or anything, because it's just not acceptable to people. The other question was about the cervical screening review, and whether there will be the lessons learned from these and the recommendations will be used by that review. And I appreciate it might not be your role, but if you could, conversations that have been had.
As we understand that the cervical screening look-back review is ongoing. I don't think anyone here has involvement in that, so we wouldn't be able to provide you a briefing or an update in relation to that, other than we understand that the look-back review and oversight arrangements for that look-back review to take place is being taken forward in the department, with similar structures to, for example, the urology look-back review and the neurology patient recall process.
And I do respect that it's not your responsibility, but going back to recommendation 2, in which it said the Department of Health must remind the trusts about who has the ultimate responsibility, that there should be conversations around from the department to the trust with what is happening with that cervical reviews, because we are getting representation at a political level as to what went on there, and we must ensure that there is transparency from the very beginning of the second stage of this review. And I appreciate, again, it's not your role, but it ties in because of recommendation 2. And my final question is regarding the accountability and those who sit on the programme board. And you'll recognise that I did have an urgent oral question to the Minister some time ago, but this is not coming just from individual parties. This is coming from people who were affected by Dr. Watts and deceased families, and families of deceased patients. Has there been a review with regards to who sits on the implementation programme board or any of the oversight boards, so that we can ensure that there is that confidence from families? We know that last week during the Muckamore inquiry, the Chief Medical Officer apologised then for the role, and again the recommendation 2 clearly states that ultimate accountability and responsibility is with the Chief Executive of a trust, who at the time the Chief Medical Officer was. Has there been a review since we asked the questions in the chamber?
Okay, well, just to start off, I think it's important to note that the department does recognise that it's important to have an appropriate level of independence in our accountability, in our structures for accountability and ensuring recommendations are being delivered as was intended. We are, the department does keep its membership of programme boards and other structures under review as appropriate. At present, I would believe that our current membership on the programme board is appropriate for its terms of reference, for fulfilling its terms of reference. In terms of the substructures that we have, Patricia has kindly already referred to the liaison group and the assurance group, which she shares, and perhaps it would be useful to maybe go into a little bit more of the detail as to the level of independence that provides. And indeed, just to emphasise that the liaison group provides a very helpful level of input from families and patients, which I think is absolutely invaluable to this process, and hopefully that should give confidence through the wider networks that those members on that group have. It should give some confidence that we are genuinely listening and taking on board their perspectives in the shaping and the sign-off of recommendations. But I'll pass over to Patricia.
Well, in terms of the assurance group, all those members are independent from the Department of Health and are present because of expertise in particular areas, and I believe you're going to meet one of the members coming shortly. Experts around the being open and transparency, experts in governance, experts in regulation. So we're independent, and we then make our recommendation to the programme board, and that board is not independent. It deals with independent inquiries, but it will be those with authority in the Department of Health that can sign off then the recommendations. Of course, they can also be critical of and look at the processes, and then look at the outcome of that processes and challenge whether it absolutely fulfills the kind of function. But as I said, they're two separate and independent.
Separate and independent, but we've also just heard that they can challenge it and not accept it. But that's not your responsibility. But I think it just outlines that, and I know we move in small circles when it comes to chief executives and management, but it just outlines the issue around confidence in it too. But thank you for answering my questions today.
Alan?
Thank you, Chair. I'll keep my questions brief, which might be refreshing. In terms of serious adverse incidents and adverse incidents, are all of those collated? Are all of those informed to people such as RQIA and others, or is there a selection criteria for what gets passed on?
My understanding is that they're not all collated and passed to RQA, but certainly the SPBG and PHA have an oversight function in relation to serious adverse incidents, and sampling goes on. But part of the purpose of the new framework is that there's a strengthened regional oversight function there, so that more focus on surveillance, data trends, that type of thing, that issues that happen in one trust can be extrapolated and benefits and learnings made in other trusts. So it wouldn't be the case that all are reported, but it is a requirement that at board level there's an executive director with responsibility for serious adverse incidents as well.
And adverse incidents, or just serious adverse incidents?
I need to just double check, because the purpose of this framework is specifically focused on serious adverse incidents. I could come back to you separately, Colin, on that.
Roughly how many adverse incidents are there in a year, and how many serious adverse incidents are there in a year?
I don't have that information to hand, but I could come back to you on that if that's okay.
And will they form part of this review?
The
adverse and
serious adverse incidents is the focus of this review. Yeah.
There's a lot of concern that adverse incidents might in turn become serious if they're not noted or observed, if they're left sort of unnoted and not collated.
I'm not sure if Patricia is aware of the adverse incident side of things, but certainly the recommendations and the reports focus on serious adverse incidents, hence the focus on that side of things.
But I would say, on a wider point around the kind of governance, that one of the good practice things that we recommend and is in guidance now will be that people look for trends. So they will look for things that are beyond just the serious adverse incident, which have its own processes that are prescribed, so that you learn from near misses, that you learn from where something wasn't as serious as it could have been, so that you have, and we want to develop and make sure that those who are providing that kind of scrutiny at the non-executive level understand the significance of that, so they get feeder reports that are through that aren't just focusing on large failures but on opportunities for learning and improvement. And I think that's the tenor of a lot of the improvements that need to be. It's not just firefighting what's gone wrong, it's about how you improve, sustain, protect, and do all those things that really learn from the experience. And an important part of that is how you react to feedback from users of the service, because it may be that something is not an adverse incident, but maybe it's a complaint, but it may look not that different from an adverse incident. It's usually on the basis of something that someone has expressed dissatisfaction about. So it's trying to tie all those things together and to look and see if there's trends in that, if there's specific things that need to be reacted to.
I sense the importance of looking at the trends and the importance of gathering, but if we don't collate that, are we not missing a trick?
I'm not sure, Colin. I would need to come back to you in terms of the reporting around the adverse incident side of things.
That's fine. Maybe come back to that. That'd be great. Thank you. Thank you, Chair.
Orlia?
Yeah, thank you. So just to follow on a wee bit from the issue that Colin raised there, so because it's interesting, it was some feedback that we had received whenever we had met with a family representative, a family member, and it was the point around if we don't sort of put the same focus or attention on the adverse incidents You know, if that was the case, then hopefully, ideally, you would be preventing the serious adverse incidents. So it's just interesting because it was actually a family member who was directly impacted did make that same point. And I suppose then that brings me on to this is the importance of actually having the people with the lived experience involved at every level and at the highest level in terms of your structures, your decision making and your outcomes. And then just on that, so I know that, and thanks very much for all of your feedback so far. So you had referenced, obviously Patricia sits on the liaison group in terms of the SAA work stream. I know in the briefing paper it was talking about the patient client council have their engagement platform, which is 5 individuals, and then the department also done an open recruitment exercise to try and identify other family members to join the programme, and that took on an additional 3 individuals. So I'm just wondering, in terms of all of the work, the important work that you are involved in, how many family members who have been directly impacted with the lived experience are actually involved in helping with the work that you are carrying out? Because again, I'm conscious with, again, going back to the SAIs, that you were saying earlier, the consultation might be going out at the end of this year. Although there's only been 2 virtual meetings with the SAI family work stream, is that correct? 2 virtual meetings and then written briefings, written feedback. So I'm really just going by the contact that has been made with us as a health committee. We're still getting contacted, obviously, you'll understand, on a frequent basis, you know, by families who have been impacted, by families who have been through one experience or another in terms of the work that you're dealing with. So it's just important that whatever's going out for consultation, obviously, that you have it's as thorough and, you know, as expansive as it needs to be in terms of what families want to see in this. Yeah. So how have you reached out to families outside of the department's open recruitment exercise? What does that mean? How was people contacted? How did you reach out to people? And even with the patient client council and the great work that they do, I'm always conscious that we probably deal with families day and daily, you know, in terms of our local constituencies, but families who maybe would be out of reach from the patient client council, but yet their stories and their lived experience is as important to feed into this piece of work. So just if you can expand a wee bit more on the families with lived experience and the outreach. Yeah,
certainly. So as you say, we've the 5 family members on the PCC platform and then 3 on the project structures who've been integral in developing the documents and have been an invaluable source of feedback on that side of things. I think I'm right in saying we're the only part of the UK who will be consulting more widely on a public basis on our SAI framework. So that is a significant purpose of that is to go beyond those people, to give those people who might be able to devote hours and hours of their time to a project like this, but at the same time they might want to feedback in terms of what we're planning on doing. So, you know, going forward, that's a key part of the public consultation process.
Okay, and I suppose then, just to bring it back, because the committee are in the process of arranging our own informal meeting with some families who would like to meet with us and speak about their individual experiences, but maybe who haven't been tied in at any sort of particular level to, you know, the work that you're doing. So, I mean, is it possible that, you know, this is obviously an ongoing process, so if there is a request for families to engage with your group, with your structure, with the liaison group, with the programme board, is there an opportunity for that to possibly take place?
I suppose we're trying to balance production, hearing from people with lived experience alongside delivering on the frameworks we have. So at the current point, we've agreed how we're co-producing this, and that's through those 2 mechanisms, and the third mechanism being a formal public consultation on that. I'm not aware of any other specific people who haven't been at least provided that opportunity to be involved in the 3 on the project structure. who are looking for additional input, but that would be available to them as part of the kind of public consultation on that. And I know there are remaining issues with the people in the PCC platform who have issues with some of the proposals, and you know, their views will be taken account of as part of that process as well. But it's where how you balance the continuing to expand that co-production and the family input, and I think we've got that balance right to date. But you know, the public consultation may well raise issues around people we haven't reached, you know, and that type of thing. But at least that there's another mechanism there to take those views on board.
Okay.
Could I just come in on that as well? I know I was getting the impression that your question was specifically about the SAI, but you mentioned the Independent Neurology Engagement Group that we have established specifically for the I&I recommendations and the implementation programme, and that door remains open, you know, to anyone. But we also appreciate that the families and former patients may not be in a position to maybe have the time, you know, to attend meetings, or it may be too painful for. They may also be considering going down other routes, maybe engaging with the PSNI investigation, or maybe have a clinical negligence claim process ongoing. And we appreciate that the position that they may well be in, but the door is open, and we have, and I know Patricia has mentioned it already, the positive engagement, the constructive input that we've had from those members, and you know, the door is open to allow that to take place and for other people to come on board that may well want to contribute to the implementation work and the vision going forward.
Okay, thank you. And well, no, I know I did reference the SAI work stream, but I was also thinking about, you mentioned the Julia Cumberledge review. Is there any representatives from the MESH campaigns that sit on your groups?
In terms of MESH, it's quite a different type of report. It's going to, our intention is that we will be bringing it under the same governance arrangements as the other public inquiries. However, it's quite different in terms of recommendations around compensation. So we're at quite a different place with that. However, there will stakeholder engagement, service user participation. Participation is absolutely key to the success of any of these reports, and we're open to and will be progressing engagement with service users, families, patients at the right point in time.
So, after the consultation, then.
Well, where we are at the moment in terms of Cumberledge and Hughes, obviously as it is a UK government led programme, we are more dependent on what steps UK government takes. So we're currently at a point in time where we're waiting to see what is happening from a UK government level, and that informs our next steps.
Okay. Thank you.
Please, Chair, can I just come in for a point of clarification from your opening remarks, and maybe to also come back to the other members' commentary about adverse incidents. To be very clear, trusts collect all this information on DATEX, which is of any threshold of an event or anything adverse, and they do the analysis of that. They do contain that information. They do report on it. So there is a centralised system for that.
I think the issue is that many of us would have is that where that's progressed to, in some cases it's screened out as such, and that's kind of the concern, that if it's not taken at the earliest possible stage, then it leads to something much bigger, which could have been avoided if it had been taken seriousness. I think that's maybe what.
Appreciate that concern.
I just have a couple of small ones, because as we were talking, and I didn't think everybody was going to come in, and that's why we kind of give a wee bit of latitude in terms of questions. But just one of the things you'd mentioned in terms of the INI was one recommendation that requires legislation. I was just wondering if you can share what that recommendation is, and when we can expect that to be brought forward, if it is going to require legislation.
It's recommendation 68, and it's specifically for GMC, and it will take national government to make take that forward as part of a reform programme, because the recommendation is specifically about the publication of information around Rule 12 hearings, whereas there's no discretion for GMC in Northern Ireland to operate outside that legal framework. So they're waiting for primary legislation in the UK government. So we have deferred that as it's out with our control. But there's no, from an I&I point of view, there are no others that will require that kind of legislation.
And just the two other things I wanted to ask. We're obviously be dealing with the huge workforce pressures that are currently existing in the health service, which are no secret. And one of the things, I mean, we've heard from many organisations, RCN, you know, and others who they say they could paint by the walls with SAIs at this stage. My concern is that, you know, as part of any implementation of recommendations moving forward, there also needs to be those protections for staff, and that looks at safe staffing. And I know we will be considering safe staffing legislation. Is that something that is being, as part of implementation of recommendations, that is being discussed with the department? Because it's okay putting recommendations in place, and that's about protecting patients. I'm also conscious that where incidents happen, people are put in front of panels and all of those things, and in some cases, not all, that may be as a result of the environment they're having to work in and things being missed. So I think that's a very important aspect of any work we're doing, that there's that twin track approach to ensuring that safe staffing levels are in place as another mitigation against incidents occurring. So is that something that is part of the work that the board is doing in terms of the department's engagement?
Just on the SAIs, you know, the documents we're consulting on later this year, there's a specific document in relation to principles for engaging, involving, supporting staff. So there's a real focus. There's a focus on those people affected, and there's also a specific focus on staff. So that's something we're taking account of as part of that. Okay,
and do you feel, Michael, then that it's deliverable in terms of, I mean, we're obviously, and you might not be able to answer this, but I do think it's a really important part of this work that we're being realistic in terms of our commitment to supporting staff. So the recommendation coming out may say that we have to ensure staffing levels are of a certain level, but is that deliverable in reality, given the funding constraints and the serious challenges across the workforce? Is that something you would have any concerns with this stage, or is it ongoing work?
Well, certainly it is ongoing, and, you know, practicing under pressure is something that is raised, you know, with us, and conscious as well that next year, in addition to SAI, a new process being open, the judicandor work, and there's also an IPSO review of complaints, all happening to trusts when they're doing, you know, lots of other things as well. So we have to be mindful of the pressures we're putting on the system from an implementation point of view. So we're mindful of those things, but yeah, it is something we need to manage going forward.
Yeah,
and are alert to it. You know, that's
something that we would be keen to see as well, because it is probably the cornerstone of a lot of the issues we're seeing across the board. And the final point is just that one of the members have asked around this is what outcome measures are being used for implementation, and our families included in part of that. So in terms of we're measuring the success or the, you know, the lack of success, for want of a better term, what outcome measures are being used, and our families having an input into that, so that they're saying we can see the benefit of this.
Yeah, I'll probably pass over to Patricia in a moment, who can give a bit more of a detail around the assurance frameworks that we have in place for each of the recommendations. Essentially, we have mechanisms in place to ensure that from the department's perspective, recommendations have been fulfilled, and then, as Patricia's already alluded to, there's various levels of assurance as to how they are continually being maintained when mainstreamed. So.
And indeed, Chair, there would also be as part of that, it would be what are the normal accountability processes to the department, what is published by trusts in their governance and controls assurance statements, what the regulators of whatever, whether it's in training or registration or any other external body is reviewing the kind of services. And indeed, one of the things that we ask trust to look at is in the new guidance around the integrated governance, is that they act on the kind of feedback that comes through to them. So we want to see that they've also been able to do that, whether it's through care opinion, whether it's through specific dedicated feedback mechanisms they put in place because of an initiative that they've undertaken. And we do expect then that the strategic performance and planning group also have an accountability process for monitoring some of those. So I think, as I said to you at my opening remarks, that you really want to do a business as usual model, not that you're saying we've got these series of inquiries because there are so many and there's so many recommendations, but that you try and make this work as a business as usual as much as possible. And I'm sure that there'll come a point in time when you start to look at the post-implementation of all of these recommendations, and that would be a matter then for the implementation board to consider at that point the look back and what it needs, if there's additional assurance required at that stage.
Okay, well, thank you all. That did go on a wee bit longer, I think, than we expected, but I think it's been very useful, and I'm sure we will have further questions as you know after we meet with the engagement panel as well. So we do appreciate your time. So thank you, and Michael. I think you're staying where you are you? Thanks a million.
Thank you.
Okay, members. So our next briefing then is on the Being Open framework and duty of candour.
Chair.
Sorry.
See, before we go on to that, might it be helpful if, as a committee, we were to ask the health sector whether they're actually going to do any primary legislation regarding recommendation 68, and if the department, if the department have asked them, and what engagements have had it with the department around that.
No problem.
Yeah, Chair, I wouldn't mind writing to the Minister in the back of that as well, because I'm not entirely satisfied with what I heard in terms of the element of the trusts kind of mark their own homework in terms of adverse incidents, and I think that there's a well of information in there that could be fed up that somebody outside an organisation, because we do know that the places are so small that somebody within a trust looking at it could be related to somebody that's been discussed, or could be worked with somebody that's been discussed and may not give it the same weight that somebody that's outside looking at it. And I think within those adverse incidents is where the serious adverse incidents grow. Yeah. And I think that the fact that they're just kind of left for everybody to look at them themselves, I think is where some of our big cases that we've discussed have come from. So I think maybe if we could write to the Minister and ask, is that something that might be considered by that panel, because it's something certainly I wouldn't be happy, based on what we've heard, that's what's been sort of left to happen.
No, I'm happy enough with that, and I think it'll feed into our next discussion as well around duty of candour and that being open as well. Diane?
Yes, thanks, Chair. Just on the back of that, one of the issues that keeps coming up over and over again is who actually holds the trusts to account. And Colin's point is very well made, but when I asked this of the Health Minister in relation to breast cancer timescales, he deferred to the Permanent Secretary, who said that there was different levels of being held to account. And when I asked him which trusts were at level 4 and 5, he didn't really, he said none, because they were just developing the system. So clearly there is an issue about how trusts are held to account for performance, or in this case, for management of issues that are of grave concern to our constituents and to health service users. And maybe if we could widen that letter to just ask for that overall accountability mechanism as well, I think it would be very useful and instructive, and might lead us then to maybe want to do a session on accountability.
No problem. Thank you, Diane. Orlia?
Sorry, just one last point. If we could also maybe add into the letter the issue around patient and people with lived experience, their involvement in this process, because I know that they were saying it's obviously an ongoing process and that the door remains open, and I'm just conscious for whenever we do that informal session with some of the families, if we can give them the feedback in writing from the Minister in terms of the co-production process.
Thank you, Orlia. Okay, members, so in attendance today, you're all very welcome. Thank you, Michael, you're welcome back. We have Michael O'Neill, interim director. Oh, sorry, Linda, I didn't see your hand up there.
I apologise. I didn't want to interrupt. I didn't want to cut across you. But just on that last point, I mean, I think all of the questions that we're asking there of the Minister are fair and absolutely should be asked. I think the one thing I would want to caution against, because I even as I listened to some of the conversation that went on in the last presentation, we need to be very careful that we're not putting in more and more layers of bureaucracy when we don't have staff to staff the hospitals. So I'm not saying we shouldn't do it, but we absolutely need to be very, very careful and very, very cautious that we don't have hundreds of people checking that the right thing's been done and nobody there to do the right thing.
I think that's a fair point as well, and I think that's maybe about taking it away from the frontline staff as well. But we can see what comes back, and I think that is a good point. So we have Michael O'Neill, as I said, Ian Plunkett, duty of candour, being open policy lead and IHRD programme manager, and Professor Peter McBride, independent consultant from the HSC Leadership Centre. So you're all very welcome. Members, we have about 45 minutes for this session, and it will be covered by Hansard again. So if I can invite you to make some brief opening remarks, then we'll open up for questions. Thank you.
Thanks for the invitation to provide an update on the development of a Being Open framework for the HSC in Northern Ireland. I'll provide you with a summary of the background to the work stream and provide an update on the current position as well as our intended next steps in the process. I'll then hand over to Peter, who'll provide you with an update on our approach to engagement, the outputs of that work to date, and emerging themes and issues. The extensive work on Being Open is developed out of the 15 related recommendations made in the inquiry into hyponatremia-related deaths to introduce a statutory duty of candour in Northern Ireland. The recommendations relating to duty of candour include the introduction of a statutory organisational duty of candour, a statutory individual duty of candour with criminal sanctions for breaches of these duties. Critically underpinning the duty of candour recommendations is a need to embed an open, just and learning culture throughout the HSE system. Following a public consultation on duty of candour in 2021, the decision of the then Minister was to focus attention on the supports necessary for staff to enable and empower them to be open and honest in all their work, as well as understanding better the impact of the introduction of a statutory duty of candour would have on the health service. The work on a regional Being Open framework was initiated in the autumn of 2022. Peter, an associate member of the HSC Leadership Centre, was commissioned by the department to lead on this work. A steering group was established with members consisting of departmental officials and independent consultants from the HSC Leadership Centre to provide direction, assist with the development of the framework and oversee the work carried out by Peter and the implementation team to progress the framework. Significant engagement has been carried out across the HSC over the last number of months that Peter will speak to. A draft of a new regional Being Open framework has been developed by the steering group with the intention of launching a full public consultation towards the end of this year. Importantly, this process will include further engagement with service users in line with our co-production principles. The framework aims to ensure that individuals within our health and social care system are fully empowered and supported to exercise candour and openness, and that HSC organisations have in place the necessary support and systems required to enable and to nurture this culture and approach. The consultation will help inform final decisions around the framework. As I mentioned in my written briefing, a new statutory duty of candour in isolation of this key cultural piece of work is unlikely to have the positive benefits we need to see going forward. It's also important to note that adopting this new framework does not preclude the potential benefits of introducing a statutory duty of candour. We've been engaging with colleagues across the UK who are all at different stages of the process on this issue. Members will wish to note that in December 2023, in response to the Hillsborough disaster report, the Department of Health and Social Care in England announced a review into the duty of candour there. This review is taking place to understand to what extent the duty is being honoured, monitored and enforced, and to ensure that the initial policy objectives are being met. A call for evidence ended in May of this year, and we continue to engage with colleagues in England to ensure that any future work in Northern Ireland is informed by the conclusions of this important review. The Prime Minister committed in the King's speech that the Duty of Candour Bill will be introduced to Parliament before the next anniversary of the Hillsborough disaster in April 2025. In addition to the related recommendations set out in the IHRD inquiry, the Infected Blood Inquiry Report, which was published in May 24 and extends UK-wide, has made recommendations in relation to individual duties of candour, with consideration to extend these beyond healthcare, and that specifically Northern Ireland should introduce an organisational duty of candour. Again, we are linked into discussions with counterparts in England, Scotland and Wales to consider these developments. Options regarding next steps for Northern Ireland in relation to duty of candour will also take account of these discussions and of related timeframes which remain under consideration. Thank you. Now I'll hand over to Peter for more detail on the engagement process and emerging themes, and happy to answer questions thereafter.
Thank you very much for the opportunity to be here. I need to put my own involvement in this in the context of the hyponatremia implementation programme. That's when I first became involved. So I was the chair of the work stream of the hyponatremia implementation process that was connected with the duty of candour. So there were two work streams that were interrelated, the implementation of duties of candour and being open. Therefore, I was absolutely involved in both the public and the sectoral engagement around the issues of duty of candour. And the distinction between the two work streams was the duty of candour focus was obviously on the introduction of legislation. The being open focus was on the issue of culture and how we adopted a culture of openness. And there were many occasions within that process that became a very, very divisive process. If I could caricature the two sides of it, on the one hand you had family members and the public saying, just introduce the duty of candour. What is there to be frightened of? This is just about telling the truth. And, you know, that's impossible to argue with. On the other hand, you had the health system getting extremely anxious, specifically about the individual duty of candour. Nobody was overly exercised about organisational duty, but very exercised about the individual duty of candour and specifically the criminal sanctions associated with it, which were proposed. And the reason for that was it was experienced by them as punitive, excessively punitive, in an environment where they were already feeling slightly under the cosh. So the challenge with this was that at the end of that process of consultation, no resolution to that difference had been achieved. We still had those two camps, and it was clear to see that there were solid arguments on both sides. The Minister at the time, then in 2021, so that was back in 2018, that process of co-production went over 2 to 3 years up until the point of COVID, and then in a form continued through COVID because it was so important. The recommendations went to the Minister at the time, which was Robin Swan, and it was clear that this was not a resolved issue, that there was not agreement across the system with the public. And you always expect a bit of tension, but this was very polarised. And therefore he commissioned this work that I've become engaged with as a follow-on from the Being Open work that was part of the IHRD implementation programme. And that was to really understand from a staff perspective within the system what the barriers were to being open. There were multiple times in that process that the question was asked, what is the real prize here? What is it actually that we're trying to achieve? And arguably both the possibility of the introductions of duties of candour and the cultural work about being open should both be servants to openness and honesty within the system. That's the prize. So part of this was understanding, A, why was there such anxiety and ambivalence around the introduction of statutory measures around candour, and B, what was the felt experience by staff around openness, because many of the questions you asked in the last session, behind them is a question of why would staff not speak up? What is it that might stop staff coming forward if they saw something they were uncomfortable with? And there's a really important question which would be, would a statutory change affect whether they would be open to doing that or not? So the work that I've done over the past year and a half has been a very direct engagement with all the trusts, including the ambulance service. It started with the Belfast Trust, and that was the most extensive engagement that I had. I'm clear about this, that this is a cultural approach. So this is not about writing a formal report. It was about engaging with people on the ground and having conversations and asking two simple questions. In terms of openness, what are the things that might stop you being open if you thought that you had done something wrong or you had seen something that was causing you concern? And what are the things that would enable you? What are the enablers in the system that might make a difference in that? On the back of that, we have a tentative framework. And it's a matrix of that sets together the challenges of being open with cultural challenges. In England, Northern Ireland is an outlier in terms of statutes, so we do not have an organisational duty of candour. The anecdotal feedback from England that I've received from staff around the organisational duty of candour in England is that it precipitates a de minimis approach. That because it's legislation, it requires prescription. So it only applies where there's a high-level SAI, and in those specific circumstances, there is a statutory duty for people to tell the truth in those circumstances. The problem with that is then the organisations tend to argue about whether a specific incident has reached the threshold for the duty of candour to apply. Because being open is alongside duty of candour, not a statutory approach, it allows us to be more expansive. So the three levels of openness that we're talking about are routine openness. How do we create a culture in the system where people on a day-to-day basis feel able to share information and freely and without any fear of repercussions? The second is very relevant to some of your previous questions, which is how do we create openness with a focus on learning? In other words, when maybe something has gone wrong, how do we create an environment where staff feel that they will not be unfairly punished, where there's the capacity for mistakes to be made, because we all know that mistakes will be made. So how do we create an environment where that can be done with psychological safety and people know they would be treated fairly? And then the third level is where a statutory duty of candour would tend to kick in, which would be where serious harm has been caused or death. So by adopting a being open approach to it, it's allowed us that more expansive approach. In terms of the culture piece, it's also important to understand the three components of culture, which are the sort of practicalities of culture, in other words, the policies and procedures, but then importantly, behaviours. We can have the best policies in the world, but if managers don't behave properly, it disincentivises staff, it frightens them. And the third component of culture is the narratives and beliefs that people have about an organisation. When I asked the question of staff, what would stop you being open? They told me stories. They told me stories about things that had happened to them. They told me stories about things that happened to their friends or relatives in the organisation. Which brings me to my final point, which is what is the feedback I've received? There is variation in the system. So not all trusts are the same, but there are certain characteristics that are, I think, general across the whole system. And that is there's a high degree of fear and anxiety. There's a lack of trust in staff in the systems that are in place to protect them, for them to raise concerns or to speak up. So when I ask the question, what is it that would stop you doing it? The kind of stories they would have told me would be that they felt that it would diminish their career, it would stop their the processes of advancement, that there would be ways that they would be caught. There was a lack of confidence in any kind of anonymity in the system. So for whistleblowing or anything like that, they didn't believe that their information would be kept private and confidential. And so with that level of, and then layer into that the challenges around a system that is under huge pressure with resourcing, it adds yet another dynamic to it. In the final point, in terms of the issues around duty of candour, the specific statutory proposals, the real danger in this is that it's seen as an either-or. Either we adopt a cultural approach with being open, or we introduce a statutory duty of candour. That's not going to work, in my opinion. Any statutory duty should support, in a way, be servant to the cultural piece. The feedback within the system is there is absolutely no objection or no anxiety around an organisational duty of candour. I think that would bring us in line with the rest of the UK, and also many other jurisdictions have an organisational duty of candour. Specifically, if we wanted to be really at the head of the game, if we were to construct an organisational duty of candour that was focused on supporting the cultural work, I think that would be a really clever way to do it. In other words, organisations have a duty to support their staff to be open and transparent, and that there are various mechanisms that allow them to do that. The real anxiety in the system is around the possibility of an individual duty of candour, and extreme anxiety around the possibility of criminal sanctions. So I think that this is a very complex issue, and it's one that needs very careful consideration in what feels like a very fragile organisational environment at the moment.
Thank you to Michael and Peter there for your introduction, and you've probably answered some of the questions I was going to ask. I suppose, as I said earlier, you've may be aware of some of the conversations we have already had at committee in terms of individual and statutory duty of candour, and you'd mentioned there about people feel that it can't be one or the other, and I would agree. I think it needs to be both. Yeah. For the reason is what we would, I suppose, certainly my perspective on this is what we would hope is that people do feel confident to come out and be open and transparent at the earliest possible stage. And in terms of an individual and an organisational duty of candour, I think that would be, in my view, I think rather than it being we want people to have criminal sanctions, it's to mitigate and deter from it getting to that point, so that they'll be open and honest at the earliest possible stage, knowing that that's the best thing to do. the hyponatremia inquiry specifically, you know, it shown how people covered up and there was real reticence to be open. So, I mean, there's been guidance in place for over 25 years to be open and be transparent, and that clearly doesn't work. And people have lost their lives as a result. So I don't think that we can rely on a being open framework in isolation any longer. And I mean, we've seen the recommendations across the inquiries. We've met with families of the infected blood scandal. We've also met with the deceased patients of Michael Watt, their families, and really horrific stories. And I think that for me, it's coming to a tipping point where we think we can't continue to allow this to go as it is. So you mentioned the indication from Westminster of bringing in primary legislation in relation to this. Is there any appetite that you're aware of from the Minister to consider that for here in the North?
Well, that's the plans around the Hillsborough one is more specific to specific events. But in terms of infected blood, it's a organisational duty of candour across the public sector, and that's so the type of questions that are being asked now, the same questions, but the context has changed in that Northern Ireland is an outlier in respect of organisational duty of candour. We don't have it. Everywhere else, you know, the UK does. But similarly, if we were to implement an individual duty of candour, we would be an outlier, in that we would be the only place with an individual statutory duty of candour. So I think timing-wise, with being open, being consulted on over, you know, from towards the end of the year, emerging recommendations or findings, conclusions from the English review of their organisational duty of candour, which has been in place now for 10 years. The timing could be fortuitous in that we learn how that organisational duty of candour has taken place. Minister's put on record his view that he wants across the public service people to be candid, etc., in their dealings with the public and what they do. But there just was that concern around a chill factor of what the impacts would be on the workforce for an individual organisational duty of candour, and I think that's I think that's a natural conversation to have at the point when the kind of being open consultation has finished and more emerges from what the plans are across the UK in terms of the wider piece.
Yeah. And you talk about that chill factor, and I completely understand. I worked in the trusts myself as a health and social care worker, so I completely get that. But I suppose what I would hope that people can understand, this is about as much about protecting staff as it is about protecting patients. I would say everybody around this table has spoken to staff in health and social care who maybe wanted to raise concerns about whether it's the conduct of someone or something they've witnessed, or I know even in terms of what they're being told maybe by management or something about an issue and being told do not contact your elected representatives, things like that. And that fear is there, and I think until we take a more stringent approach, that will continue, and we're going to be round in circles on these issues. So I do appreciate that, but I think we're meeting with the GMC and others as well in the time ahead, and I think these are the conversations we'd like to have, because it is about protecting everybody. It's not about trying to come down on people with a criminal sanction. That's a complete last resort. Where that's necessary, that should be happening. But as we talked about in the previous briefing, some of the issues that arise they're not deliberate. So if we can get that addressed at the earliest possible stage, then ideally that's, I think, where we would all like to be.
If I could just respond to that, I understand the logic of that completely. I think the real question is, will it work? And the feedback that I've heard from staff is it is unlikely to work in terms of the individual and criminal sanctions. And the danger with this are unintended consequences. And setting Northern Ireland, for example, apart in a competitive environment for particularly for medics, to have a system which is apparently more punitive. And I take your point completely. This actually should provide people with more protection. But the way it is likely to be experienced by staff, and this is the nuance in this, is that it becomes more punitive. That would have certainly been the impression given during the last consultation. Then there is a danger of unintended consequences, and I just say that as something to be cautious about.
Oh, and I take your point, and I think that's what we would like to explore as a committee as well. I mean, I don't think anybody's going to rush into anything without considering, you know, all potentials. And I would like to explore a wee bit around unintended consequences, or what staff foresee as the challenges around that, or why they think it wouldn't work. It's also important that we do look at what's happening elsewhere where maybe it is in place. But I think it's important that we have these conversations and we look at this in the round, because if this can protect lives, yes, which for me is key, I certainly don't want to be seeing more and more of these inquiries coming down the road, because not only is it affecting people's lives and people are losing their lives, it affects families, it's generational, but it also puts huge pressure on the health service as well. I mean, these inquiries cost millions of pounds, take years and years and years, and I'm not talking about just the big inquiries that we've alluded to as part of these discussions. Some of those more serious adverse incidents as well, which in many cases, in some of the ones I've been dealing with, there were numerous opportunities to stop something getting to the stage it got to, and they were all missed, and the people were failed. So it's about addressing all of those things, and there's no perfect answer to any of this, but I do think it is something that we really want to explore. So I'm going to I could go on, but I'm going to go open up to other members. I know there's many looking to speak. So Nuala.
Thank you, Chair. Thank you for that. It was helpful, especially around that engagement piece with the trusts. And I just wanted to come back to the bit that you were discussing around the argument from trusts that it may not meet the duty of candour or the threshold. And it was just to clarify that. Do you mean trusts in England and Wales where there is an organisational duty of candour? Do you know of what has been put in place though to prohibit trusts from maybe kind of putting in their own mitigations to stop things from reaching the threshold?
First of all, it's important to say this is anecdotal, so it's coming from those who've been involved in it, and what we heard was happening. So the definitions around duty of candour are linked with the SAI processes, and above a certain level, for SAIs above at the highest level, then the duty of candour applies, but not below that. So, you know, the facetious implication of that is you have to tell the truth if it hits a particular level, and if it's below it, you can do whatever you like. I'm not saying that's what happens, but and that's why I call it a de minimis approach. It takes the least, the route of least resistance to try and get the minimum outcome. Whereas I think what we're trying to do here is to have a whole system approach, try to create a culture of openness, so that when something does go wrong, when those circumstances are hit, people's instinct is to be open and transparent, rather than this being something that, right, there's a duty of candour and now I have to do this. So it's just the difference with, I think it's a fundamental difference between it is a difference between a legislative framework which requires definition and a cultural approach which allows for more expansive engagement.
And I do understand that, and I do understand the fear from staff. I understand that they would have a fear, but I think it's really important, especially for us as committee members, when we look at the individual duty of candour, is that it would only come into effect where there were instances where there has not been full disclosure. And I think that's really, really important to highlight. It is not a witch hunt against anyone who makes a mistake, because we know that the majority of our health and social care staff act in good faith. Mistakes happen, like that's the reality, they do. It's what follows on after.
But in a way that's the problem, because I think that any of the legal experts that we've spoken to would say that an individual duty of candour would have such a high threshold, it would be in really exceptional circumstances that it would apply. So there's an argument to say, well, how does that work then as a disincentive? And the reality is then staff experience it as a threat. There's this threat of the duty of candour. The reality of it is unlikely it would ever hit, which is part of the rationale that we might have for saying, you know, it's not going to be used very, very frequently, but staff on the ground experience it as a personal threat. This is something that's going to affect me. And I am relatively sanguine about this. I think that this is very complex, because while I have engaged extensively with the system, I've also engaged extensively with the public and families. So I know the depth of feeling around this. And I go back to my point that I made earlier on. What is the actual prize here? And the actual prize is that we don't go through, as you've said, Chair, another set of inquiries where the same issues around non-disclosure come up. O'Hara, when he did his, going through the hyponatremia inquiry, clearly became really irritated with not getting an honest experience of information out of the system. And that's just not acceptable.
I agree, absolutely. And I do think that though there are many families who don't feel it is complicated though, and for them it's what are you covering up. And in 2019 or 2020 it came to light that in just one ward of Muckamore Abbey Hospital there were 1,500 crimes. And just recently when Kathy Jack gave her evidence to the Muckamore inquiry, she actually stated to that inquiry that when those staff knew that the CCTV cameras were on, behaviour was changed. So that says to me that those who out there are willing to cover up, are willing to actually act not only negligently but criminally, they will look again if there was something like CCTV, perhaps something like a legislative duty of candour. And I don't know if you have any role in terms of the adult protection bill, but that the bill proposals, we haven't had it, will place a statutory duty on the trusts, PSNI, HSE board, etc., to provide health and social care services to report to the relevant trust any cases where they believe there is a reasonable cause to suspect that an adult meets the criteria of an adult at risk and need of protection. So to me that just says that a duty of candour would actually strengthen that in a positive way. There's already legislation in place. So could we anticipate that maybe perhaps the adult protection bill, which our understanding now is delayed, could now include the duty of candour? If we're going to have the Be an Open framework next March, it does need to be both. So perhaps could the department now look at as to whether the adult protection bill could include the duty of candour?
Yeah, I just haven't been involved in that side of the work there. The other thing, just touching on, and so I'm not too sure what the answer to that particular question is, but the other thing on the the anecdotal side about whether or not it works and unintended consequences, the English Review, which has finished their evidence gathering now, will at least provide us with conclusive non-anecdotal information about what the unintended consequences of that have been. On the point of the bill that you're referring to, I would need to double check just what the plans around that are, and what the legal kind of framework is around that.
Well, I think it would be helpful if you could, and I think what's very important is that every opportunity that the department does seek is to reassure that with staff that this only actually would ever come into effect where there wasn't full transparency or disclosure, and indeed you could actually have levels in terms of mitigations within legislative proposals for whether it was deliberately withholding disclosure. Like, there are different levels in what it can be. So I know that the actual law of itself could be complex, but there are ways to actually do it. But it's important because after all, when it came out regarding Dunmurray Manor, and it talked about duty of candour, when hyponatremia was the very first recommendation, probably going to happen with Muckamore. We're going to finish it. We're going to have to actually decide once and for all to do it. And our preference, and my preference, would be that it's leaded from the department. But I would not be so shocked or surprised that if a private member or amendments were to come forward to include it in any other way, because it needs to be done.
Okay, Danny.
Thank you, Chair. Just a couple of questions. There clearly has been a long history of issues where dishonesty, withholding information, covering things up, deliberately giving misleading information has come up in the various inquiries that you have mentioned again and again and again. Families that have been pushing for those inquiries for many years and then finally getting them, and then they see the recommendations and they see duty of candour as part of the recommendations. How do we convince those families that, despite everything that has been pushed for throughout these inquiries, how do we not deliver duty of candour for their loved ones who have, in many cases, been seriously injured or passed away? How do we not deliver for those families?
I think it's a really important question, but it creates a very binary view of this. The introduction of statutory duty of candour will not solve these problems. They won't. It's an end in itself, and it may go some way towards creating a framework in which people will be punished. But the mechanisms beneath that, through which people are either incentivised or disincentivized to tell the truth, are something much more complex and to do with context and all the rest of it. And I go back to my point, when I talk to families and this issue comes up, like I said, I'm sanguine about a duty of candour, but I think, success here is not that we introduce a duty of candour. Success is that we have a more open and honest health service, and that when things go wrong, people feel empowered and safe enough to speak up about it. That's success. And my real concern actually is the unintended consequences bit, that we, introduce a statutory duty of candour, tap ourselves on the back and say, right, that job is now done. When actually the fundamental problems that are going on underneath, which I've alluded to and which are becoming clearer and clearer, are not being addressed. So I would want to engage with the families about, in this regard, about what actually is it that we want to achieve. And duty of candour will be part of that answer, but it is certainly not the whole answer.
I'm conscious that obviously it's been mentioned time and time again. I was reading back for 20 odd years. I think even in the 80s, I think it was the first time it was mentioned, that this is something that needs to be implemented. And I think it would be very hard to explain to families who have lost a loved one and why that isn't being implemented as it. And I get what you're saying about
I understand.
the culture. The culture piece has to come, and I agree with what has been said, that they both have to happen together. Having worked in the health service and having had a lot of briefings here through Health Committee about the pressures within the health service at the minute, I can absolutely see how staff would see this as a threat. The pressures that staff are under within our health service at the minute are growing, and in those environments you can see how mistakes can be made when wards are understaffed, when they have excess numbers of patients, when our A&E departments are overcrowded. You can absolutely see how that would lead to mistakes being made. But this isn't about punishing people who make mistakes. It's about punishing people who cover up, who lie, who seek to deceive. And I think that distinction has to be made clear. You mentioned the threshold for the duty of candour in England. I'm curious as to what that threshold would be that would be so high that it would take to trigger it. Are you talking about a patient death?
Yes, so it was the highest level of SAI is where it applies.
So only in the cases of a patient death does duty of candour apply?
Only in the case of a high level SAI, so it doesn't always equate to serious harm.
But just organisational.
Yeah, and it's just organisational. Not individual, but most professional bodies have a duty of candour as part of their professional standards. Which
I was going to come to that. As a nurse, now certainly the NMC would be investigating. That would be the oversight body for nurses, and there would be an investigation, and they would look for dishonesty, and that would be part of it. And as such, a nurse who's found, and similarly, I think for the GMC, would be found to be struck off. What I was going to ask then is, what are the sanctions that apply for an organisation who is found to have broken? Yes.
A fine.
A fine?
Nominal fine. And I don't know the up-to-date statistics, but there have been very few.
The first prosecution was 6 years after the implementation of the law, and that it was, I think it was £12,000 or £13,000 from maybe a local authority, a trust. But there haven't been. So I'd imagine a key part of their review is how has the enforcement of this law worked, and a big return to what were the policy objections and have they been met? We do. I think it is fortuitous that is happening at the minute, and we will have some key information coming from that review.
There's no other sanction apart from a fine. So there's no threat of deregistration, for example, or.
Because it's organisational.
It's organisational, so
it's not individuals within the organisation. It's this sort of generic organisational responsibility.
An organisation can't be taken out or can't be punished any other way.
It's not my understanding.
No, I think it is just
fines.
And even before that, that there will be stages of enforcement in terms of. I think that's what was referred to why it took so long to initially prosecute, whereas that that it wouldn't just go straight to a fine. There would be organisations may have been given opportunities to change policies or change tack, but the fine was the final and full punishment at the end of the case.
Just my last question then, just in the absence of, and I know we've spoken of a duty of candour, how can you be sure that the being openness culture that we're looking for is enough to ensure openness and transparency?
And a very binary question. I don't think you can. I think this is, when you're dealing with culture, then all the issues around context become incredibly important. So you know better than I do, the system is under incredible pressure. And the issues around being open are, there are issues in this, for example, around the trust and our culture's attitude towards mistake making. So all the evidence, for example, shows that an environment in which mistakes are not actively punished, but there is a restorative approach around it, where staff are then feel safe to speak up if something has gone wrong, is much better for patient safety. But that is not something that's at all attractive to the public. And it goes back to a point one of the members made early on about the loss of confidence. I would say that this is the single biggest challenge that we face. The public have lost trust in the health service. And the danger with that is that the response to that is to bring in layer upon layer upon layer of accountability, which just sifts the whole system up and does not actually improve patient safety outcomes. It doesn't. I think there's lots of evidence to show this. So there's a really important engagement and conversation that is required to happen now with the public about how we deliver health services and how they understand. Modern medicine is risky. The delivery of services in a constrained environment is risky. The staff that are working in our health service are making life and death decisions every day and trying to manage really difficult risk. And so, understanding what it is that actually supports them to then, in that context, be open and honest and transparent is a really important question to ask. And the answer I've been getting, certainly around the duty of candour, is that it just simply won't work. It will have a negative impact in that way. But that's not to say there aren't other reasons for doing it, but it depends what we're trying to do.
Absolutely agree with your point about the public losing confidence. Yeah. We get that all the time. I get that on the doors in my constituency, waiting lists, people not being able to get through. But I would add to it, staff as well. There's a very, very serious moral injury that our staff feel very, very painfully. And they have lost confidence in the health service. So, that's something that, we have to consider as well.
Just on that confidence issue, I think it's about the service, and access and the confidence in the service. But there's still very high ratings of confidence in doctors and nurses. So people, the vast majority of people's experiences in hospitals, they rate the doctors and nurses very, very highly. So right across the sector in terms of all employment groups, doctors and nurses are right there at the top. I think there's a people's confidence has been shaken in the access, the provision of the service, and how they can rely on the service. So it's kind of two elements to that confidence question, I think.
We have staff at the minute who have lost confidence in, many staff who are suffering huge pressures, and even some considering industrial action as well.
The idea of moral injury is a really important one. I mean, the feedback that I got from staff was nuanced in the sense that they trusted their colleagues. They felt that they could be open and transparent with their colleagues, that they could share with their immediate colleagues if something had gone wrong. Their lack of trust was with, inverted commas, the system. So the layers of management above them, where they didn't feel that they would be treated fairly or openly or in a way that was actually interested in learning. They felt they would be scapegoated. So there's an interesting nuance. The other thing about Northern Ireland is small enough that our health service is the public. There are vast numbers of the public work in the health service, so there's a really important interface there.
Linda.
Thank you, Chair, and thank you for the presentation. It's been very interesting, and even just having that conversation around the duty of candour, I suppose that's been had and people have given their views of that. So I just want to have a wee focus on the other side of it, and that is the cultural and the openness. So I suppose the issue for me is everybody thinks that people aren't open because they're afraid. But very often people stop being open because what is the point? I have repeatedly reported issues, or said that something is not working for a particular reason and it's making it unsafe, or it's causing a risk to patients, or about an individual, and they feel they're not being listened to. And I mean, I think that sometimes that can be down to individuals within but that can also be down to the system. And we need that person, or we need, I don't have time to deal with that, so I'm not going to. So I'm just wondering in terms of that, because for me we need to address that now, because any of us as human beings, human culture will definitely tell you, if you keep saying something's wrong and nobody's listening and nobody's doing anything about it, you just get to the point where you either say, I don't want to be here anymore, or you know what, I'm just going to keep my head down, get on with my job, I'm not raising it again. Because very often those people who keep raising the issues actually end up being the people who you're almost punished for raising the issues. Keep quiet, get on with your job, it's not hurting you. So I think that that's another side of it. People often think it's around the fear, but it's actually often around the what's the point. That's the first bit around it. And then the accountability, and I accept what you're saying. It was actually a point I raised at the end of the last session around we need to be careful not to have so many layers of bureaucracy and accountability that we're not actually allowing, we're not putting that investment into the people to do the job to prevent the things from happening. So I accept that, but accountability does need to be had. And I mean, even when we talk about that last issue there in relation to Danny's, or the last answer in relation to Danny's question around the organisational duty of candour, and it's a fine. Who's paying that? The patients who suffered. You're paying the fine for your injury. That's the reality, and that is the reality of it. But there does need to be some accountability. So, and there are plenty of layers there that need to be held accountable. And accountability doesn't mean punishment. Accountability means, what have you done? What have you tried to do? What have you been prevented from doing because you're not being resourced to do it and allowed to say that? So, there's a lot of work needs to be done, and I don't expect it to be done overnight, but I do want to understand a wee bit more around that end of it, about how do we deal with the what's the point? Because if people feel nothing is being done or can be done, they're going to stop raising their hair.
I respond to that, yeah. I couldn't agree with you more, Linda, and it's for that explicit reason that the second level of openness is openness with a focus on learning. And that is because we had the consistent message coming through from staff in exactly the words that you have just said, that when one of the disincentives around being open with learning was whenever I raise a concern, then nothing is done about it. So that's why that has a section on its own. That's why that's a specific focus in the being open framework, and how we begin to deal with that. The challenge around accountability is a really important one, both in terms of dealing with that issue about public confidence, but also around reassuring staff that they are going to be dealt with fairly. Because I think at the minute there are staff who feel that accountability means punishment, rather than accountability meaning taking responsibility and being able to make amends for what has happened. And I do think this is a really important question that needs some detailed understanding. I believe there is an effort in the trusts to move towards more restorative models around mistake making, for example, but it's in the face of significant challenge and opposition because of the anxiety around what that means in terms of accountability. So this is a really important issue that requires public engagement, but it's one that unless we deal with it, that we're not going to deal with this issue of public trust.
Thanks, Linda. Alan Chambers.
Thanks, Chair. Peter, you alluded on a couple of occasions there in your earlier remarks about the concept of unintended consequences, and as politicians that's something that we have to recognise when we're crafting legislation. But in your consultation engagements, did you get any sense of feedback that if there was a legislated duty of candour, that if it was in place, would it have any negative impacts on clinical decision making in relation to patients' treatment?
So the feedback that I got specifically from medics would be that it would, for some of them, and it was only for some, there was the risk that it would lead to what they described as defensive medicine. In other words, that the possibility of them taking clinical risks, which would normally be in the purview of their professional judgment, they would have a heightened anxiety about doing that. And that would lead to defensive mechanism, and in their view that was a step backwards then in terms of the quality of service that was able to be provided. The second issue was about for certainly for specialisms and for medics, if Northern Ireland is out of kilter with the rest of other jurisdictions, either the UK or others, then the possibility of in a way that is perceived, doesn't matter, in a way it doesn't matter the intention behind it, if it's perceived to be punitive, then the challenge which we have of trying to recruit people into Northern Ireland as senior doctors is their view is it would be compromised. So those were the two main negative consequences that they saw. And again, let me be really specific about this. It was particularly the individual duty of candour with criminal sanctions.
Yeah, I mean, we're trying here to improve patient care and so forth, but in actual fact there's a possibility that we could be doing, in certain cases, doing the opposite. I can imagine, say, a clinician, and he had a patient who had a condition and they were going to die with that condition, maybe within days, even within hours, and the doctor felt that there was some intervention that he could attempt, but would actually led then to an accelerated death of that patient. He's not going to take that. He's not going to take that chance, and that's not a good outcome for patients. Thank you.
And Diane.
Thank you, Chair. So it's a really interesting conversation, and I accept that there are unintended consequences, and there's consequences to everything. But surely, on the 28th anniversary of young Claire Roberts' death, and after having to go to court, go through inquiries, and only for persistent parents and family, they might never have really discovered the truth behind their daughter's death. And that's why people want accountability in the system. And I think that that's really important to say in a meeting like this, that it is because we have to drag it bit by bit by bit out of the system that there is the demand for a duty of candour. And it's the same if you look at the debacle over smear tests in the Southern Trust. 17,500 women had to be reviewed. There are women who are not with us today because of that debacle. And I'll quote again the case of Erin Harbinson, who passed away a few weeks ago. Her smear was misread in 2012, 2015, and 2018. I understand the unintended consequences, but you can also understand why people are demanding more from the trusts and the organisation. And I'm not including individual staff. I don't think that that's fair, because I do think in many ways our staff are broken by the conditions that they have to work in. So I suppose really giving those two things. And again, I'm going to go back to something that the Health Minister and the Permanent Secretary said last week at the Health Committee, when I asked them about who holds the trust to account and how do they account for decisions in relation and performance of the trust and decisions about what information is released. It really transpires that I don't know that there's an awful lot holding the trust to account, except the Minister themselves. And do you think that earlier interventions and better accounting mechanisms would be better at this stage as well? I mean, I still think that we do need a duty of candour. I think it has gone on for so long, but I'm also interested in how we can get those mechanisms at all levels that ask for accountability.
Thank you, Diane. Did you want to respond? Are you happy enough? Yeah.
No, I agree. I mean, I think that there is not too much disagreement out in the system about the value of an organisational duty of grandeur, especially if it is focused, as you say, Diane, on how we support staff at all those different levels in those circumstances. I think that would be actually welcomed, and that would be seen as a supportive thing. So I 100% agree with you.
I think it's well.
So, like, make no mistake. I veer towards the individual as well, but I do think that we don't have mechanisms to hold trusts to account, and that is to our detriment. And we've seen that in Northern Ireland, sadly. We've seen that.
On the individual duty of candour, I think it's one of the concerns is that in an unchanged culture, that's why the cultural piece is so important. Yeah. And so, people are envisaging the individual duty of candour with criminal sanctions in an unchanged culture. So the culture, that's why the cultural change is so important in that respect.
No, and that goes back to my original point around we have to have both. In my view, I think we need to have both, so that we never really have to enact that kind of criminal sanction route, unless, I mean, at the end of the day, we know of cases where people have acted with impunity, and that's why we've ended up with the inquiries we've seen that have been referenced today. So we can't, and we're able to voluntarily deregister themselves and all these things that came with it, which, I mean, is shocking in this day and age, given we know the scale of the impact of their actions. And I think the key to all of this for me is that engagement with the sector, but the families' voices and the public voice needs to be a part of that. And as you said, Peter, the public are our staff as well. So it's about putting it across so that people understand what we're actually trying to achieve. And for me, the ultimate goal here is ensuring that we are, I don't think we can ever completely eliminate the risk of these things happening, but we're doing everything that we can to ensure they don't, and making people feel safe in their work, but also when they're in the hands of healthcare professionals.
I really hope that the consultation that we're just about to go into around the framework is an opportunity to raise those issues and have that debate with the public. I'm not a civil servant, so I view this as part of the co-production process. The framework is written as a draft, and the possibility now is getting really meaningful engagement on it, so that it creates a bit of a platform for these complex debates to be had, and for the public to be able to engage with the system a bit to understand this. Yeah,
no, I think you're 100% right, and as well as that, I also think that duty of candour isn't the answer to all of our issues here, but I think it's a very important tool that we should really be exploring and looking seriously at. But thank you all. I mean, I think that's been a really, really important and useful discussion, and it'll certainly help us as a committee, so we really do appreciate your time.
Thank you all very much.
Thanks very much. Okay, members.
Could I come in just with a quick question in terms of talking here today? I've heard this in a couple of recent meetings about the lack of accountability that trusts are being held to. Do we as a committee not have the power to summon any trust to come before us on any issue? So it's not fair to say there's no accountability. And if we are saying that, then we're failing ourselves. We're making ourselves a bit of a paper tiger. But if we have the power and the authority to hold trust to account, then we should be aware of that and use it as and when required.
Yeah, no, you're 100% right, Alan. We do, and we do have the trusts. I think they're actually coming again now before Christmas.
21st of November.
So
that's routine, but I mean,
at any time, again, on any issue,
the trusts have done something really let the public down, we could summon them.
Sure. Yeah, and just before I take you in, Nuala, I think the other point as well is there's an independent board set up in every trust area as well, which are that is their role. And maybe if we do have concerns around accountability, that's something that we should be looking at, in terms of how that is functioning and is it fulfilling their duty as well. Nuala?
I was just going to say, I wonder if the comments, I think Diane had made it mostly about the accountability of trusts, I think, but it was off of the back of the statement from the Minister earlier this week, in which he said, I don't agree with the trust, I don't like what they're doing.
In terms
but
of
I can't
services.
do anything about it, you know. And that, I think, I mean, I don't want to answer for Diane, but I mean, I know that we'd had a chat, and that's, you know, I had concerns around that, and it's something that we can certainly come back to at the 21st of November. But
my understanding around that, if it's in relation to the maternity services, is that trusts have the authority to make temporary operational decisions, which I was aware of, but any permanent decision would be taken with the department. So I think it maybe is how it was communicated, maybe came across.
Communication issues though as well were brought up with
that's
staff
it, and
too,
that's something we've been dealing with.
You know, you can say I'm not happy with what the trust is doing. Well, do something about it then. You know, and I think, I don't know if that's just what Diane was if that was an example of what Diane was getting to.
Yeah, go on ahead.
Sorry, I just can I come in there, because I do think it is important. This isn't get at the trust day. I just think that there needs to be formal accountability mechanisms so that we understand and the trust understands what that accountability is. I mean, I genuinely don't think it's good enough for every trust to miss their 14-day target in relation to breast cancer referrals. These are time-critical issues, and every trust misses that target. But I don't know how we can hold the trust to account for missing the target and make them do better. That's what, and I don't know what the formal process is. And maybe I'm conscious that health is a new policy area for me. Maybe I'm missing that. But I would like to know, and I did ask the Minister, and the Permanent Secretary said that we're developing the accountability mechanism.
Well,
so I would genuinely like to know what that accountability mechanism is, because you cannot continue to have poor performance but never be held to account.
Yeah, I think maybe if I could suggest that, Diane, because I think that's a good point, is that, I mean, this is one of our priorities in terms of accountability and promoting good practice. So would it be possible that we write to the department to explain, to get an understanding of what the current accountability mechanisms are in terms of the trust? If they are looking at accountability mechanisms, then obviously that maybe they're changing what the current mechanisms are. And if we could extend that to then the role of the boards, in terms of how they hold trust to account as well, because I do think that from recent engagements I've had on a local level, there has been some concerns around what that accountability looks like as well. And I think that was kind of came out in the conversations we've had this week with the Minister in the Chamber, in terms of the communication between trusts and him and his department as well. So if members are happy to do that.
Sorry, can I just add to that? And you and I are probably having similar conversations about similar issues, given the two hospitals that serve our constituents. It's really concerning when the Minister says the trust informed the department very late about a particular issue over maternity services. And I'm not happy with the trust for that. So what can they do about it? You know, what does that formal process look like? Or is there one? I don't know.
And that's what we need to understand. I know in relation to that particular issue, I've been engaging with the Permanent Secretary and the Minister quite a lot over the last week, particularly on this, and there is work going to try and deal with that specific issue. But I think the point you're making is around.
It's a wider point.
It's a broader issue in terms of how. I think that's fair enough. Nuala, did you still want to come in? Are you happy enough?
I wanted to ask the question with regards to the boards. And the Chief Executive sits as a non-exec member, I think is my understanding. They can correct me if I'm wrong. But with regards to the overall accountability piece and all the inquiries, it does need clarified in terms of who actually sits on the boards and the role of the Chief Exec. It may not be, necessary now. There may not be an issue now to deal with that, but I think for future,
just for understanding, I think it would be useful because it does tie in with what we have identified as one of our priorities as well. So, Okay, no, thank you for that, members. Members, the next item is, and we're going to have to probably go through these a wee bit quickly now because we are well over time. Item number 7 is the written briefing on Respite Services. It's at page 304 of your pack. Obviously, we did have the announcement this week in relation to Children's Respite Services, and we had the motion, I think, that passed on Monday that my party brought around Respite Services as well. So the only thing I was going to ask is that if we could write to the Minister in relation to respite for adults with learning disabilities, and what work, if any, is happening, given that money has been secured for children's, because I know that's certainly a question I've been asked on the back of this week's announcement, and we do know budgets are tight. We welcome the announcement, but it's important, I think, to keep that focus as well, because I know certainly one of the issues I have is that adults with learning disabilities, I mean, I have a young person in my constituency, I've maybe mentioned this before, who's been offered respite in a nursing home at age 24, and that young person could be treated as a child, if that makes sense, if you understand where I'm coming from. So in terms of the appropriateness of what's being offered at present, I think it's a huge issue. So if we could ask that, somebody indicated there, Danny, sorry.
Yeah, similarly, I've been contacted by representative of a number of families who haven't been able to access respite services for adults for over a year and a half. And, you know, it's having a huge impact on them, particularly older carers who haven't been able to have that. And certainly carers training is a huge issue, and certainly I'd be very keen that we get that letter.
Oh, absolutely. Thank you. Okay, item number 8 then is the committee inquiry on access to palliative care services, and we have a written briefing in relation to that, so I'll just refer you to the clerk's briefing on draft questions for the committee's call for evidence on citizen space at page 305 of your pack. Do members have any comments at this stage? No? And just thank the clerk and the staff for the work so far. It's been excellent, and I think the feedback from the sector as well has been really positive that we are taking this forward. So,
but I didn't have comments because, you know, I haven't had the experience of actually being involved in palliative care, so I think it's just engaging with that families is key.
Yeah. No, and I think if there's anyone that has suggestions on the back of that, to feed them into the clerk. Okay, thank you. Item number 9 then, correspondence. The correspondence list is at tab 9.1 of your pack at page 312, and then tab 9.16 of table papers at page 3 of your table papers. If I could refer you then to the correspondence from page 313 and in table papers from page 4. That we have a departmental response at page 313 regarding the timeline for general dental services contract and on general dental services. I do have an issue with this because we asked for a timeline and we didn't get a timeline, so I think we do need to go back in relation to that, because I know from our briefing with the BDA earlier in the year and then with officials, we are keen to see what that is. So if we could go back to the Minister on that. Has anyone else any other issues on that one? No. The other one I want to just bring to your attention, members, is the invite to attend the review conference in relation to children's social care services, which the Reimagine Collective have sent across to us. So if members can confirm with the clerk if they are planning to attend, it's on Wednesday 27th of November from 9:30 a.m. to 2 p.m. at the Crown Plaza Hotel in Belfast. So just I think it is important if we can respond to that, particularly given our work on that issue. Okay, thank you, members. Are members content then with the suggested actions for the remaining items of the pack? Nuala?
I'm just into the table papers. I don't have it open in front of me. It's not working. And the dermatology letter that was sent in.
Yeah.
Can I just confirm what that action is?
Just for note.
Well, I was just wondering if we could propose a letter in support of them asking for a review of the guidance from the Medical and Health Regulatory Authority. They're not asking us to oppose, they're just asking us to support reconsidering. England or Wales have done it. Scotland are en route to doing it, and they're asking if Stormont can. They're not. I've been very clear. It's not about opposing the new guidelines, because there's obviously they're scientific, there's evidence that has been taken, but the guidance that has been issued is, with regards to, it's not about the burden or the balance of evidence, it's about the additional opinions needing two instead of one. You can still prescribe, so it's not changing the ability to prescribe, it's kind of placing a higher burden. But I think we are safe to ask for ask that they would reconsider, not that we would oppose if the committee supports that.
I mean, I'm happy with to support if they want, because I think they want to meet with the MHRA anyway. Yeah. So I'm happy with that. But in terms of the actual issues they've outlined, I don't think we'd be in a position to say we support or oppose that element of it in terms of the.
No, yes, but are we able to issue a letter to say we would support in their request for you to reconsider? Just review. Not that we would support or oppose.
Yeah, Diane.
Yeah. Sorry. So just very, very quickly, I noticed that there's a number of letters in about the public health bill. So just to be absolutely clear, the committee did have a brief on what the consultation might entail. It was fairly high level, and it was months and months ago, probably one of our very first briefings, probably. What will the committee's scrutiny of the consultation process be? Just so that I'm clear about that.
Can I just finish sorry, Dan, I thought you were coming in on the same issue, but just before we answer can I just finish just so we're all agreed there. Just our members happy enough to agree then that we support the request for our meeting and for to be looked at? Yeah, is that okay? Sure. Sorry, Diane. But yes, go. So in terms of the public health bill, I think Keith, you're planning to respond then with the processes.
Yeah, sure. Just those that have written in, I will respond directly with to let them know what the committee processes are. But as far as next steps, the consultation's now closed. What would happen normally with a consultation is once it's closed, the department will do an analysis of the responses. That will then be provided to the committee, and at that point we will get briefed by the department on next steps, with detail of that analysis of responses. At that stage, again, I don't know what decisions the department may make following consideration of the responses, but that will normally be the process. We have it scheduled in at the minute for, I think it's the 14th of November. But that could be subject to change, because I know the consultation ran a bit longer than what was the original plan. So the next step is we would get briefed on the consultation and the analysis, and then the next steps of what the department's going to do.
Okay, thank you. That's fine.
Thanks, Diane. Are members then happy with the suggested actions and the remaining items in the correspondence? Okay, thank you. Item number 10 in the forward work programme. Members, the draft forward work plan is in your meeting packet, page 394. We have, just to remind members, on Monday we have the committee's engagement event with VOIPIC with the young people in room 29 here from 12 p.m.
It's probably just before 12.
Just before 12, so even maybe if we have 11:30 in our diaries, and the young people are very much designing the programme, so if we can get as many members who can be there, and if you can't, please let Keith know. Are members content then to note the briefings as set out in the forward work programme for the rest of Teresa? Have any members any items of business they want to raise at this stage? Any other business? No. Okay, members, so the date, time and place of our next meeting is Thursday the 7th of November at 2 p.m. In the Senate chamber. So we have a joint meeting with the Justice Committee on the right person, right care discussion. So thank you all very much.
Committee Room 29, Sound. 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 Committee Room 29, Sound.